Okay, members, we're going to commence the meeting. If members could take their seats, please, for the meeting. The very first thing I want to do then is to say good evening to everyone, and that would apply to those in attendance in person this evening in the Grange Council offices in Omagh, and those attending via WebEx for this evening's informal meeting with representatives of the Western Health and Social Care Trust. Now, this is an informal meeting, but this meeting is being streamed live on our YouTube channel, and I'm aware that this evening's meeting will be watched with interest by many residents, and I extend a welcome to all who are watching the meeting as well. So, by way of background, at our council meeting in December, members expressed concerns at the continuing uncertainty regarding the removal and desired reinstatement of emergency general surgery at Southwest Acute Hospital, together with some of the evidence provided by the Trust members at the Assembly's Health Committee regarding the decision to temporarily remove emergency general surgery, and then the more recent suspension of the consultation into its permanent removal. I welcome that the Trust have accepted this invitation this evening, and I want to acknowledge the strength and seniority of the delegation. So the format of this evening's meeting will, the really substantive part at the beginning will be a presentation from the Trust, followed by contributions from members. You know, that can be in the form of comments or questions. So there aren't formal decision-making powers in the context of this evening's meeting, you know, from a council point of view. And all proposals and suggested actions will be logged with the intention of these being presented to the February council meeting for formalisation or otherwise. So at this stage, I want to hand over to the Chief Executive of the Western Trust, Neil Guckian. And Neil, perhaps you would like to introduce your colleagues. So there you are, Neil.
Thank you, Chairman. Just start by introducing, on my left is Mark Gillespie, who is the Director of Surgery, Paediatrics and Women's Health. On my further left is Dr. Brendan Navery, the Medical Director of the Trust. And in front of me, I have Teresa Malloy, who's the Director of Planning, Performance and Corporate Services. Beside her is Geraldine Mackay, Director of Unscheduled Care, Medicine, Cancer and Clinical Services. And we have Chris Curran, Senior Communications and Public Affairs Manager. And we have Shane Breen, Assistant Director of Integrated Care and Systems, with us today as well. And online, we have Donna Keenan, our Executive Director of Nursing. We have Karen Hargan, our Director of Human Resources and Organisational Development. And we have Bernie McCafferty on behalf of Dr. Maura O'Brien, the Director of Community and Older People Services. So thank you, Chair.
Thanks very much, Neil, for that. And if I could just encourage members attending via WebEx to switch on your cameras, please, for the purpose of this meeting. And without further ado, Neil, I'm going to turn to Mark, is it?
Oh, well, I'll just do a short I'll
yeah.
do the first slide.
Okay, over to you.
Don't worry, I'll not be speaking for long, Chair.
No,
okay.
We welcome.
Thank you, Chairman. Just to maybe open by saying this is likely to be my last meeting with Council, as I've announced my personal retirement. But I do want to begin by acknowledging the significant pressure that hospital and community services are under recently. I believe it is appropriate to acknowledge the work done every day to keep services safe. We're so proud of the team in SWA, in our community settings, and in all our facilities. I recognise that this is a specially convened meeting, and thank you for that, at your request to be updated on emergency general surgery. It has also been referenced at Council that the Trust have not commented on the SOAS roadmap, and tonight we will take an opportunity to do so. We have a presentation to give and to provide a core information to inform the Q&A session, Chair. And you all now have the detailed briefing on everything being presented tonight in advance of tonight's meeting. So what are we going to present on? First of all, there will be an opening statement and introduction to where we are. There will be then a timeline, information update and outlining of the Trust's current position in relation to emergency general surgery. We will then outline the Trust's response to the SOAS roadmap, which you have much more detail on in the briefing today. We will update on investments in this area, and then we will conclude on the next steps on the engagement on a vision plan for Fermanagh and West Tyrone Health and Care's futures. So I'll start by handing over to Mark. Thank you, Mark.
Okay. There you are, Mark.
Thank you, Chairman. Just as the Chief Executive has said, council members will have received from the Trust detailed statements in advance of the council meeting tonight. And one of those statements is detailing the timeline on emergency general surgery and provides information on why the service was temporarily suspended and what the Trust's current position is. And I will touch on some of that as I move my way through the presentation. If I can then just start with the timeline and the Trust's current position. In December 2022, the temporary suspension of emergency general surgery at SWA came into place. It was implemented in December 2022 as an emergency measure and a matter of public safety due to significant and ongoing difficulties in recruiting and retaining the required consultant workforce, which meant that there was no substantive consultant general surgeons available to work on the emergency rota at the hospital. This decision was taken in response to immediate operational risk and was not a decision on a permanent configuration of services. In June 2022, the position was further influenced by the introduction of the revised emergency general surgical safety standards by the Department of Health in June 2022. Next slide. So a bit more information just with respect to the timeline and the Trust's current position. In line with the statutory obligations and the Department of Health guidance on change or withdrawal of service, 16th of January 2023, the Trust launched a 12-week public consultation on the temporary change to emergency general surgery at South West Acute Hospital. The consultation process was carried out fully in accordance with the Department of Health circular on change or withdrawal of service and the Trust's approved consultation scheme. An extensive and wide-ranging programme of engagement events were undertaken, including 7 face-to-face public consultation events, 2 online consultation events, dedicated staff engagement and information sessions. Trust Board then published a findings report in July 2023. So continuing with the timeline and the Trust's current position, in June 2025, Trust Board approved the decision to proceed with a public consultation on a permanent change to emergency general surgery in June 2025. The Health Minister asked the Trust to pause that consultation and begin a process of producing a vision plan, emphasising how the South West Acute Hospital will meet the health needs of its current and future population. On the 7th of October 2025, Trust Board formally agreed to close the public consultation and start new work to design and develop a vision plan, a forward-looking programme focusing on the people and the place of Fermanagh and West Tyrone. Important just to point out in this slide that despite incorrect information recently stated in public, at no point during the consultation process had the Trust taken a decision on a permanent change to emergency general surgery at South West Acute Hospital. The temporary consultation was undertaken in good faith and in line with the statutory requirements in order to gather information from the public on their views and concerns about the impact of the change to help inform future decision making. So, if I can then just talk through some of the operational improvements, which some members in council will have already been briefed on previous occasions. Ambulatory care is the first aspect that I'll deal with. And ambulatory care is a concept which allows our patients previously admitted to have their care on an outpatient type basis. Historically, patients were admitted for observation, assessment, a scan, and senior review. However, investment in diagnostic services allows timely access to radiology investigation. This allows same-day access and patients to be seen then by a senior doctor and a decision made with respect to discharge, admission, or reassessment on a further follow-up day. It allows direct access to a senior doctor for advice or same or next day assessment by GPs with direct access by a telephone. National evidence tells us that patients like this model of care and it is indeed safe and effective. Modernising our patient pathways also allows for more efficient use of beds and minimises the need for travel, ensuring that our patients can have their care close to home by an appropriate doctor. From the 12th of December 2022 up until November 2025, we have seen those numbers grow in terms of those patients being assessed in ambulatory care, having their surgical care in Southwest Acute Hospital under the care and supervision of a suitably qualified surgeon. From the 1st of April 25 up to the 30th of November 2025, we've seen 5.6 patients being seen there, and that has continued to grow. And we will continue to engage with general practitioners and the wider public about accessing this important and crucial service moving forward. Next slide. Okay, many of you will be aware of the direct to bed piece and the information that we've previously given on a number of other council meetings. Important to recognise that from December 2022 to April 2024, the performance of patients going direct to a bed in Altnagalvin following assessment in Southwest Acute was not what we would have wanted it to be. And we recognise and acknowledge the experience that our patients and their families might have had during that period. However, we did reset the system from May 2024 and seen 78% of patients going direct to beds from Southwest Acute directly to an inpatient bed, and with a number of weeks often achieving 100%. From the 7th of May this year to the 14th of December this year, this figure has increased to 95% of patients going direct to bed. It is really important to point out that clinical priority for an inpatient bed is really what we will gauge with our clinicians. And this sometimes, in terms of the severity of illness, will always overrule patient hospital of origin. This is essential for patient safety and is made by a senior doctor. Just to say that the 95% going direct to a bed, this equates to 2 patients per week who do not go direct to a bed. That's 2 patients who do not go direct to a bed. And just to point out that this is not having an impact on numbers attending Altnagalvin Emergency Department. Thank you, Brenda.
Yep, thank you. So we can just move on to the next slide. So the Trust is now fully compliant with the revised emergency general surgery standards, which were introduced in June of 2022. Now, these are evidence-based safety standards. They're developed by consensus by a large group of senior surgeons across Northern Ireland, which did include those who worked in Southwest Acute Hospital at the time. The compliance has required significant transformation of our workforce. We've established a 24/7 upper GI bleeding rota. We're the only trust outside of Belfast to achieve this. Effectively, you need to think of these standards they're basically the minimum of what is required to provide a safe emergency general surgery service. This is what everyone should aspire to. And we have, with a lot of effort, managed to get there. Other things we've done, we have a new interventionist suite, and we've recruited a specialist interventional radiologist. We monitor our outcomes using a company called CHKS. This is a company, it's a large multinational company. Every trust in Northern Ireland, England and Wales uses them for their data and their figures. Next slide, please. So looking at the data and the analysis from CHKS, we've compared the combined outcomes of Altnagalvin Southwest Acute to the outcomes when it was only provided in Altnagalvin. And when we look at the different time periods, we can see that mortality has reduced by approximately 14%, surgical complications have reduced by 21%, and readmissions have also fallen by 22%. Now, we've recently had some interactions with CHKS, and they will be providing further analysis. That is going to go up to the end of April 2025. Now, this date is fixed because after that, we went live with our new electronic system, Epic. And after that, for a short period of time, there will be no further data that will be sent to CHKS. That's the way that it is across the rest of Northern Ireland. So the improvements really, and the way that we need to think about this is not a Southwest Acute Hospital issue. The improvements we have, these are for all of the patients in the Western Trust area. What we've done is we have tried and we have worked with our staff. We have met all of the standards. We're the only trust, apart from Belfast Trust, who's fully complied with the standards. And we have shown that this has benefited all of our patients. Thank you.
Thank you. If I can then just move further on in my presentation, just and focus a bit on patient experience. You'll all be aware of the RQAA review, and one of the recommendations on that was that we gather patient experience. As an organisation post the temporary change, we had been gathering patient data with respect to experience. However, RQA had suggested consideration should be given to a more purposeful approach, and we engaged then corporate nursing with the director of nursing and engaged our care opinion team as well. Patient feedback then on emergency general surgery. We issued 555 surveys between January and April 2025 with 107 responses received. That's a 19% response rate with some telephone follow-up to make sure that we garnered as much in terms of response rate as possible. Without that telephone follow-up, we would only have received 6.3%. Overall experience from those who responded was that 77% of patients rated their experience as good or excellent. Improving how we listen to patients. The methodology then was updated in July 2025 following our programme board, where we looked at a number of options again to improve those patients feeding back to us. As an alternative, we issued surveys directly to patients on ward before discharge, and ward level tracking was introduced to ensure full coverage and data accuracy. If I can just focus on a number of the comments that were provided through that in relation to each of the areas. Care at South West Acute Hospital, the majority agreed or strongly agreed that care met their needs and they were treated with dignity and respect. Care at Altnagalvin then, the majority agreed or strongly agreed that care met their needs. Family or key people were involved in decisions and some patients felt less listened to. Ongoing engagement then continues with respect to our patients via QR code or paper copy, and this can be returned before discharge or can be returned by post when the patient is discharged. These patient experience findings are important when we look at patient experience, when we look at patient outcomes. And given that, these were presented to our ITI committee on the 3rd of December, which has got representation from non-executive directors of Trust Board. Surveys were issued to patients from May to July also of this year. Thank you.
Yep, go ahead.
Oh, sorry, I need one more slide, sorry, apologies. So current position was the bit that I just needed to finish off on, if that's okay. What is the Western Trust current position? Delivering emergency general surgery at South West Acute Hospital would require full compliance with the mandatory Department of Health revised emergency general surgical standards at South West Acute Hospital. This would necessitate significant additional investment, including interventional radiology, renal services, and an accelerated bleeding rota. Such services have not yet been commissioned for South West Acute Hospital. And with respect to the department and an official statement, the review of general surgery Northern Ireland sets out evidence-based standards for emergency general surgery, and hospitals delivering emergency general surgery must meet these standards. Any decision on a permanent change to the delivery of emergency general surgery at South West Acute Hospital will require approval from the department. Thank you, Chair.
Okay, thank you, Mark. I just thought it would be important to finish this section of the presentation by the Western Trust commitment to the South West Acute Hospital. South West Acute Hospital remains an important acute hospital within the Northern Ireland Hospital Network, and its acute services provision has not changed. SWAP provides a 24/7 Type 1 emergency department, maternity services, obstetrics and gynecology, full resuscitation facilities, and an intensive care unit. The Trust is also fully committed to contributing and supporting fully, where appropriate, to cross-border collaboration, including through partnership work already underway with SEALJA Group, whereby we are working towards a memorandum of understanding in the next few months. But also, we're working with partner organisations to identify further opportunities for cross-border collaboration and support, particularly for border counties and border acute hospitals. We are committed to keeping SWA a vital and sustainable acute hospital, open and transparent engagement with the public and stakeholders, which Teresa will develop further, and developing a meaningful long-term vision for health and care in the area. Thank you, Chair.
Thanks very much.
We'll just go on then now to the next section.
Okay.
Teresa and I will pick up.
Sure, Teresa's on here. There you are.
Good, Chair.
I'll just put you back on here, Teresa.
Okay. Thank you, Chair. Thanks, Neil. So I think it's important that we update council members on the investments that have been happening within our hospital and community services in Fermanagh and West Tyrone area. Members are already aware that SWA was selected as an elective overnight stay centre by the Department of Health, and they did that at the end of 2022. And as you know, OMA Hospital and Primary Care Complex was designated a regional elective day procedure unit before that. And really from that time, 2022, additional investment in hospital services for those two hospitals began to flow. So in the table, I've set out the sort of timeline for those investments and the type of investments that we've seen in both our elective care and also unscheduled care. So we have had investment in endoscopy, in OMA and in SWA, a considerable additional investment, 16.5 new sessions. In imaging, both MRI and CT, just this year, we've been commissioned for an additional 12 sessions in South West Acute Hospital, 2 MRI sessions and 10 CT sessions. In gynae services, just this year, we've been advised that the Commissioner will invest in an additional consultant in SWA, which will enable 2 additional outpatient sessions and 2 additional inpatient theatre sessions and a day case theatre session. And for general surgery, we are in negotiations this year for additional investment in that area in elective care. And for general surgery and urology, when OMA was designated a DPU, we did have an investment for an additional 7 sessions for the region. For unscheduled care, through the No More Silos programme and through funding that was designated within the Trust as growth funding, we have invested in same-day emergency care with 4 additional assessment bays in SWA ED. We have had 4 additional intermediate care beds in OMA Hospital, and we have had additional pharmacy support in SWA ED. And across the hospital's investment since 22, we've seen therefore 7.4 million of investment in elective care, and that does not include what will come, we believe, this year for general surgery, and for unscheduled care at 1.6 million in that period. Next slide, please. Hospitals is not the only area where we've been working hard and allocating investment with support from our financial planning processes. So we've had a number of community investments. We've had our expansion of our home care transitions team with increased home care and reablement capacity in the Greater Fermanagh area. We have increased our capacity in nursing home beds, and we have now an additional 21 general nursing beds, 13 in OMA and 8 in Castlederg. And Council, I'm sure, are aware of the GP multidisciplinary teams, which is a model whereby trusts employ and provide staff into that team, and GP federations and GPs provide staff into those teams. So we provide the physiotherapists, and just this year, the lead physiotherapist and 4 physiotherapist practitioners will be allocated to practices in the federation area. I think it is important to also mention, it's been a really important development and a very different development for the Trust, is that we have been approached in recent years to support GP surgeries which had notified they wished to hand their contracts back. And in this geography, in Fermanagh and Tyrone, we have supported 3 GP practices which were at risk of closing. And in those situations, patients are dispersed to other GP practices, putting pressure on the remaining GP practices, as I'm sure you would know. So we currently manage practices which support 22,000 patients in this area with GP services. And that would not be available if the Trust had not agreed to step in. The community investments are at the order of about 1.6 million over this short period. Neil, I'll hand back to you now for the next slide.
Thank you, Teresa. Part of Chair, is really for us for the first time to be completely transparent in our position in relation to the SOAS roadmap. We're providing the trust position, and we hope for engagement with SOAS in moving forward, and we welcome all dialogue as our work progresses. We intend to meet SOAS in the coming weeks. We have tried to meet, but a meeting didn't go ahead before Christmas. We have a provisional date now, so we hope to work towards that. We respect the work undertaken by SOAS in producing the roadmap. We recognise the deep interest and concern within the community about the future of health and care services in Fermanagh and West Tyrone. We have basically, there are three groupings of recommendations, Chair, and there are those that align in one way or another with our current work. It mightn't be exactly the same as what we're doing, but they align with our current work. There are recommendations that we cannot support at this time, and there are recommendations requiring regional or cross-border leadership. So what I would propose to do, if you want to move on to the next slide, I would propose just to group the recommendations into the three groups. I don't propose to go into every recommendation, Chair, and go into detail. We have provided the detail to all members, and we will take questions in relation to that rather than spending 20 minutes on the 20, and they do deserve a full 20 minutes. We have 9 recommendations that we believe align with current work. There's the return SWAT to major trauma, recommendation 2, and recommendation 5, the pay and conditions, recommendation 6 for the council to develop community involvement network, recommendation 7 about the 2 unused theatres, recommendation 8 in relation to the unused beds, recommendation 10, the subspecialties, recommendation 11, the accelerated elective programme, recommendation 12, the SWA OMA links, and recommendation 18, the Green Integrated Surgical Network, which we believe we've already done. There are 4 we cannot support at this time for reasons that have hopefully will become clear as a result of the presentation tonight. Firstly, commit to restoring emergency general surgery. Secondly, develop separated emergency elective surgery, which is linked. Recommendation 4, they develop the PACU, the post-anaesthetic care unit in SWA. And number 9, reopen 22 surgical beds and restore staffing. There are actually 7, we dropped one off there, if you notice. There are 7 that we require regional or cross-border leadership. And that is recommendation 13 for the North-South Ministerial Council. And the recommendation 14, that's about central border councils, including Fermanagh and Omagh District Council, to identify and develop areas of potential hospital-based cooperation. Recommendation 15 for SWA to receive emergency cases along the north-south border. Recommendation 16 for SWA to operate as a receiving trauma centre. Recommendation 17 to build elective capacity for agreed north-south shared specialties. Recommendation 19 to develop a comprehensive integrated funding plan, and the recommendation 20 rural area hospital status. So that's our position in relation to SOAS roadmap. We have given the background to each of those, why each of those recommendations are in the group that they are in. Hopefully that's self-explanatory in the paper. Can I just point out one thing in relation to completeness in our presentation, Chair? In relation to the outcomes, we've highlighted the improved outcomes. We have to be completely transparent. There is one outcome, which is in relation to length of stay, which due to the ambulatory unit taking the majority of patients out of the comparison, there has been a slight increase in the length of stay, and that was to be expected. We expected it before we implemented, but we just want to be completely transparent in that as well, Chair. So really then I'll just hand back to Teresa in relation to the next steps to finish off the presentation.
Thank you, Neil. Thank you, Chair. This section of the presentation will give a little bit more information and insight, I hope, into the steps that we are beginning to take to do the groundwork and preparations for Fermanagh and West Tyrone Health and Care Futures vision. We know, as you do, that the Trust Board made a decision in October that we would not only close the consultation, but that we would proceed with this visioning work. And since then, we have been undertaking early stakeholder engagement with externally and with our staff. And I'm sure members of this council are well aware of that, because we've met, I believe, with all but one of the parties, which was unavoidable and being arranged. And we've spoken to parties very openly about the approach that we've taken and provided quite a lot of information. We are working really hard on our staff engagement staff are members of this community and have had a difficult time at a highly pressured period. We've established specific mechanisms to engage with staff and to help them advise us on this work, how we do it and what it's finding. I hope you are noticing that we have placed a lot more information in the public domain through our communications and our public relations arrangements, including much more information than probably councillors or the public would have seen about the breadth of services that we provide to this community from our hospital, but also from our community services and primary care services, of course, which I've referred to earlier. So the work we have underway at the moment, and it is in an early stage, is really talking more and having a new narrative about the work of the Trust and the services that our staff provide, really improving our communications, particularly to political and media and other external stakeholders, and being really careful and thoughtful about our staff engagement and testing and delivering our new approach and our new narrative with all of those stakeholders. We're at the planning stage now in widening and getting ready for widening community engagement. We're very familiar with all of the networks that are available. This council uses a wide range of networks and we do ourselves. So there are very, very similar groups that we talk to and work with, and we're getting prepared for that engagement. And we're looking at innovative ways to undertake this visioning work. We're taking on board external expertise and new ways of looking and thinking about the engagement with all of the people who are interested in this work and want to be part of it. And in those three boxes, really, we need to be very content that the work has been done solidly and we are clear about our way forward before we would consider launching a new engagement and involvement approach and starting the visioning work in earnest. That is an agreement we have with our Trust Board, and it is in line with the careful and staged approach that we've agreed to take with this work. Next slide.
Okay.
So what we hope to have as an outcome is at the end of this work is a sequence of steps that take us towards the development of a vision plan with people and place at the heart of it, and with SWA as a hospital integral to that work. We understand that there are important dependencies in this work and things that might set it back or throw it off course. But we do believe that very solidly it must be based on population, health and care needs of the Fermanagh and West Tyrone area and the future projections of those needs. We need to consider not just the Trust services, but increasingly primary care, community and voluntary sector and community care interdependencies and interfaces. We want to be very live to research about the role of rural hospitals and how rural hospitals can integrate with community and primary care services. And we're very conscious that in the Minister's Reset Plan, there's a policy development that might be very important to us, and that is the neighbourhood model of care, which really is about working with and within neighbourhoods to understand needs and design services very well at a neighbourhood level. And of course, the intention is that we will enhance our public engagement and our involvement using much more innovative ways to do that. We have put resources, a small team, a project management office around this work, and we have secured support from the Leadership Centre within Health and Social Care and external experts. And I think really in terms of timing, it will take the time it takes. We are determined to take a very careful and staged approach and be sure of our ground before we move on to the next step. I did feel, Chair, it was important that on that very important foundation of population, health and need, there was a little bit of reflection for Council just about some of the information that's in the public domain and that has been shared at a place level with the Trust and with Council, Councillor McElduff as a member of the AIPB. You'll all know the Health Inequalities Report is refreshed every year and gives us a picture, a bird's eye picture of health inequalities across Northern Ireland, and I'll come to that. We've done work, our Pathfinder report, which was really heavily contributed to by the Public Health Agency and a public health expert, Declan Bradley, gave us a lead in to the areas which at that time were important to the population. We've done our own analysis. We have a document called Population Health West that brings together sources of information and triangulates them. And we were provided during last year with a place-based analysis by the Public Health Agency. And I'll come to that as well in the presentation. I think it gives us some useful material for our thinking. This is really a snapshot of health inequalities for Northern Ireland. The Western Trust straddles 3 council areas: Causeway Coast and Glens, Derry City and Strabane Council, and Fermanagh and Omagh Council. I won't talk about Causeway Coast and Glens. As you know, we are just a part of that council area, not the whole council area. And I suppose I just draw council's attention to the stark differences in terms of the comparisons between the Northern Ireland averages on a range of health inequality measures for Derry City and Strabane and Fermanagh and Omagh. In Fermanagh and Omagh, of the range of metrics, 23 of them are approximately the same or similar to the Northern Ireland average. 8 are better, and 1 is worse. In Derry City and Strabane, 15 are roughly the same as the Northern Ireland average, and 17 are worse. And I put this in front of council just to draw to your attention the very big differences there can be in the populations that we in the Western Trust serve, and the fact that we do need to ensure that the services that we design, develop and deliver are finessed to meet need rather than the same for the whole population. More detail in the next section, and this is the last one around population health. I did mention the information that Councillor McElduff, as this council's representative on the Area Integrated Partnership Board, received, along with ourselves and the other members of that board, from the Public Health Agency. Chair, I think we all found it a little complex, but there are some really key messages perhaps that council will want to reflect on after meeting today. PHA were able to look at population health indicators at a district electoral area. There are 80 of those in Northern Ireland, and they did an analysis based on a heat map approach, with red and dark red as being really things you don't want to see, and green and dark green really indicating a population whose health is good. The indicators that the PHA selected are self-reported, and this is how people view their own health, and that's from a formal census that happened in 2021. And the rest is statistical data drawn from various sources about health and health outcomes. So that's male life expectancy, potential years of life lost, the standard rate of potentially avoidable deaths, smoking-related deaths, lung cancer incidence, chronic heart disease registered patients, dementia registered patients, and long-term conditions in the Northern Ireland Multiple Deprivation Measures 2017. So if we perhaps move on to what was presented to us by the Public Health Agency for Fermanagh and Omagh. So this is your heat map, our heat map. And across the various DEAs, right from Enniskillen to West Tyrone, you can see across all of those areas of ill health or self-assessed health where that DEA is assessed to sit. I mean, it's important to draw out that the 3 that really stand out for this council area, which is Enniskillen, Erne East and Omagh, all have targeted work going on in those areas. In Enniskillen, That is an area that has been identified by the AIPB for targeted work. And your own Integrated Health and Wellbeing Network, chaired by John Boyle, has already begun work on, in Erne East and in Oma. So those areas are really getting quite close attention. If we look at the things that would cause most concern right across your geography, I think you can see that chronic heart disease and dementia are areas of really significant concern. Next slide. I have just given, for your information, the Derry, City and Strabane equivalent heat map. You can see there are significant numbers of dark red and much more red. And it's just again to make that point about the difference in the geographies and the needs in the geography. You will see the Moor as the number one, not a place you want to be, the worst life expectancy for males. And that there are really significant issues in smoking, lung cancer, and dementia. Chair, I think that concludes the presentation. Hopefully members will have indulged me that this is the work that we're building on and the evidence that we must be informed by. Thank you, Chair.
Thanks very much, Teresa. Okay, is that the conclusion? Okay, thanks very much to each of the trust representatives who presented in a composite style way. So I'm going to go now to those councillors who are indicating either in the chamber or online. I have two in the chamber who are indicating. I go first to Councillor Gannon.
Thank you, Chair, and I'm sure you already knew I would have plenty of questions. The first one, Chair, is in relation to slide 4. Despite incorrect information recently stated in public, what does the Trust mean by that? Specifically.
Okay, could I just maybe insist on a few questions for the Trust representatives to collate and respond to? How many questions have you, Adam? Just indicate if you don't mind.
I haven't, well, that question, there may be follow on depending on the answer to that question.
In fact,
And then I have about 5 questions.
that's okay. That's okay. And you're
Not like me to have so few.
you're not restricted to 3 minutes on this occasion.
Yes.
Okay. All right, go ahead.
So if I would like to come back on that one. At that November Assembly Health Committee meeting, Dr. Lavery had said that I think it was HPSS did significance testing on the trust-wide mortality, the RAMI, before and after removal of service. Obviously, that's something I had asked Dr. Lavery about previously. Would the Dr. Lavery be willing to make those calculations and all that data publicly available and sent to council? Further to this as well, Dr. Lavery had said he had done an analysis on mortality by GP postcode, in which he said or implied that mortality decreased in the Fermanagh and Tyrone area. Again, can that data also be released? That was something that I know I specifically had asked for back in July about specific data to this area. I do want to then quickly ask about the question about the vision plan has been covered, I think, sufficiently there. In the health committee meeting that I'm referencing, the board outlined that due to the new clinical standards and the clinical interdependencies within a range of services, that there would need to be a commissioning of several new services to be able to, in theory, bring back emergency general surgery, regardless of cost effectiveness as a discussion. Can the Trust just confirm that the Department of Health would have to step in and commission these, in theory, for a emergency general surgery return? And the final question at this stage, Chair, is around patient experience versus outcome. Meta-analysis of surgical intervention shows that a worse patient experience does lead to poor outcomes, including greater risk of complications, adverse immune responses, inflammation, impaired healing, etc. I'm sure the doctors would know more than myself to be specific on that. And whilst the Trust have said mortality have went down, would they agree that even with the mortality, that the worse experience could lead to those outcomes, and a worse medical outcome and a slower recovery for patients. And finally, in relation to this, obviously there's surveys being done, but we all hear very horrific patient experiences still. What steps are going to be taken further to improve the experience of patients from Fermanagh or those transferred from the Southwest Acute Hospital? And I might come back in if that's okay, Chair, after.
Thank you.
Okay, Chair, if you want, I'll start and
Yep,
I'll start
please
by
do.
answering it. You're in relation to page 4, Councillor Gannon, you've referred to a comment despite incorrect information recently stated in public. What we're saying there is at no point during the consultation process had the Trust taken a decision on a permanent change to emergency general surgery at Swell. It is in the public domain and social media that decision has been made, and it hasn't. I just want to reassure you. In terms of at the Health Committee, I was very clear to the Health Committee that if emergency general surgery is to return to Southwest Acute Hospital, it would have to be different to the previous service. That is the lines. It would be a different, therefore it would be a different service. That does not mean we've made a permanent change. That means exactly what it means. If it is to return, it has to be a different service. This is consistent with the Department of Health statement. It is also consistent to our original consultation. And we have the slides, if you wish to see, the slides which we presented during our initial consultation for the temporary change. I would like to read out my press statement that I gave back in 2023 in relation to the consultation event. I'll not read it all out, Chair, because it is a few pages long, but I'll read out an excerpt. We recognise how difficult it will be to reinstate emergency general surgery at Southwest Acute Hospital due to both recruitment challenges and the requirements for access to other clinical services within the new regional standards for general surgery published by the Health Minister. Southwest Acute Hospital falls some way short of meeting the requirements of these standards. Delivering safe care to the population of the West was the primary reason for this temporary change. We are satisfied that the temporary suspension of emergency general surgery at Southwest Acute Hospital and a new pathways put in place to assess patients in our ambulatory pathway at SWA and to treat patients requiring admission at Altnagavin has significantly mitigated the patient safety risks which arose from the challenges in the consultant general surgeon workforce. So I believe that's the point we're trying to make, Councillor Gannon. In the public domain, it's been said that with permanent change has been made. There's been no decision on a permanent change. So that's the first question. The second question in relation to CHKS, I'll pass over to Dr. Lavery to answer.
So I'm going to give you a comprehensive answer.
Put on your.
Yeah.
Just turn it off.
Get there eventually. So we have no evidence of any adverse or poor outcomes post-temporary change to EGS. Now, part of the issue is that we have low numbers of patients transferred from Southwest Acute to Altnagavin. It's approximately 2.5 per day. This means it can be difficult to reach the amount of data that you require to get statistical significance. However, with the figures that we have, which currently date up to September 2024, when I asked for HPSS analysis of that, that gave a p-value of 0.058. Now, for it to be statistically significant, it has to be less than 0.05. So that means that the figures that we have, there's less than a 5.8% chance that they have occurred just due to chance randomly. So they do not reach true statistical significance, but they are very close. Now, one of the things, though, that we have to deal on, though, every patient death or adverse outcome is very, very important. And we really can't dismiss good patient outcomes. You know, these are really, really important for patients and for ourselves. I can confirm my personal reaction, if these figures were the opposite way, would be very, very different. The reality is we do not have evidence of patient harm here. At the time of the temporary cessation of EGS, we were very significantly challenged. We were told that there would be multiple adverse outcomes for patients. The reality is there's no evidence that this happens, and the available evidence is supportive of decreased death rates. Now, you've specifically asked for some breakdowns. So the mortality rate that I have for emergency general surgery patients by GP practice postcode, specifically from the southern sector, from January 2020 to November 2022, was 3.17%. Now, when we look at the combined service, which dates from December 2022 to September 2024, that mortality is 2.67%. Now, we're going to get a report from CHKS within the next 2 to 3 weeks, and that will have further analysis. That'll have another 7 or 8 months worth, and also the data at that point will be effectively complete, because due to the new EPIC system, we'll be unable to add any data for a short period of time until that is resolved. Okay, so really, while these figures are all very good, I think the next report, which will be available in the next couple of weeks, will really hopefully put this to rest.
Okay, in terms of question 3 in relation to the standards for emergency general surgery and in relation to commissioning, I suppose I'll answer that in a number of ways, Councillor Gannon. The first is, the Western Trust has one interventional radiologist. According to the standards, you need interventional radiology full-time, Monday to Friday, at the very least. One interventional radiologist can't cover 3 counties of Northern Ireland. It's just physically impossible. So for us to actually bring that service back, we would need additional interventional radiology for the West. That is not something that the Western Trust can do. That's something that would have to be up to the Department of Health to commission if they decide to commission it. I think a bigger challenge, because that's one person, so you would say that could be done. I think the bleeding rota is the biggest, is one of the biggest issues. Bleeding rota, I think Dr. Lavery said we are the only trust outside Belfast has been able to achieve a bleeding rota, and that's because of the consolidation of consultants on the Altnagovan site. Quite frankly, you would need a lot more consultants in Southwest Acute Hospital to have a 24/7 consultant bleeding rota. So there are other linkages, such as renal services, which we'll need a satellite renal service in Southwest Acute. I'm led to believe, but those are the core. I think the interventional radiology and the bleeding rota are the real core. Also, when you look at the actual separation of an emergency and an elective rota, that's down to then you would need a significant number of consultant general surgeons based solely in the Southwest Acute Hospital to achieve that as well. So there are a lot of challenges, Chairman, in relation to the standards, and it's quite significant that a number of hospitals in Northern Ireland are struggling to meet those. In terms of question 4, I'll pass question 4 and 5. Probably I'll pass to Mark beside me. Well, we do question 4
I'll do
first, and
question
we'll
4,
get
okay.
to question 5.
Okay, so look, as a director responsible for surgical services, I care deeply about the experience of our patients. I'm also a nurse on a professional register. So outcomes for patients are important, but the patient experience is equally important to inform how we best develop the services and the care that our patients receive. We acknowledge and accept that the number of patients that went direct to an emergency department in the early part of this change was not acceptable, and have really focused hard on coming months to actually improve that. But not only have we focused on that piece, we've actually done extensive work with the clinicians and with the consultants with respect to clinical audit. And when we've looked at those presentations of the patients who have come through ambulatory care, and we've looked at every patient that's been transferred as well, the reason why we've looked at it was to see and assess whether we could improve the experience and the journey for those patients, and ask ourselves difficult questions. Do those patients actually need to be transferred? So from that clinical audit work, we have developed a repatriation pathway. Historically, patients who were older people who had fallen and banged their head came to Altnagovan for a period of observation. We have now plans in place where those patients can have that period of observation in Southwest Acute Hospital with the medical team. We've also tried to develop ambulatory care, and we see those numbers coming up. It will be really important that we will work alongside our GP partners to make sure that we continue to build upon that. But when we looked at clinical audit, we looked at every clinical presentation that came to Altnagovan. And when we looked at that, we identified a number of cohorts of patients who could, for example, patients who required laparoscopic cholecystectomy or their gallbladder removed, but didn't need it done immediately, and patients who had requiring what we call incisional drainage or a wound being drained. Those patients now do not come to Altnagovan where clinically appropriate. We book those patients to an operating slot in Southwest Acute Hospital or indeed Altnagovan. And just to say that is not a process that is a one-way process from Southwest Acute. Coming from Southwest Acute, we actually have done that same process in Altnagovan. So patients who present with those clinical presentations to Altnagovan get booked into OMA and actually get booked into Southwest Acute as well. We've got a finite amount of bed stock, so we need to use that and use that appropriately and use that well and make sure that we're putting the patient in the right place. It's key and important, given the geography, given the road network, that we, where possible, we minimize the impact for patients, but not just for patients, for the family and the relatives who've got to make the journey to see those patients, often twice a day. So it's something that we're really cognizant of, that we monitor on a regular basis. And that clinical audit piece is not a once-off piece with the surgeons. It is something that happens on a cyclical way. And we will continue to amend that and work with GP partners to see how we can maximize the absolute excellent facilities at Southwest Acute that have got really good radiology in terms of ultrasound and CT, and continue to focus on keeping the volume of patients that we can close to home where clinically appropriate and safe. Thank you, Chair.
Chair, I think, Councillor Gannon, I think Mark has also answered your fifth question mostly, but I do want to add in as well, in fairness. I think we have to recognise that the experience for some patients in the health service across Northern Ireland isn't what we would want it to be. There was no point in me sitting here but saying otherwise. So, but we can't single out one particular specialty and say this is a particular problem. It is a problem because of the pressure on staff, the pressure on beds, and the capacity in the health service generally. We always focus on the experience and the outcomes of patients when they enter into our facilities and into our services. The growth in the number of patients, when you see the slide there, and the growth in the number of patients in the Southwest Acute Ambulatory Unit shows a genuine commitment to really pushing the boundaries to explore, to ensure wherever clinically safe that patients can stay wherever possible in Southwest Acute Hospital. We know more now than we knew when this first happened, because it was an emergency change, as you know. We now know that due to clinical audit, we've really challenged the clinical leads, and the clinical staff have really challenged all different things that can be done in Southwest Acute versus what can be done in Altnagalvin. And finally, Chair, I've been on a leadership walk around in the ward in Altnagalvin where these patients come to. And I can assure you the nurse manager in that ward is totally committed to the patients within that ward. I was astounded at the fact that the low number of complaints, probably one of the lowest number of complaints of any ward in Altnagalvin, the KPIs that she's focused on, the compassion in that ward was really, really obvious to anyone walking onto the ward. So I just want to pay tribute to that staff as well. And okay.
Okay, thanks for that. I'm going to come back to you later. Adam, you can distill your thoughts on what you've just heard. I have about 6 other speakers who need to come in now, but I'm going to come into you about 4th. Just in the interest of making sure that everybody's heard, I'm going to come back to you probably in about 10 minutes. But in the meantime, I'm going to go to Councillor Coyle.
Thanks, Chair. Yeah, I've got a few questions as well. I'll also declare an interest because I work in the hospital, and I just want to really carry on from what Neil said there. I want to commend all the staff that work in the hospital, and it under very difficult circumstances at times, and especially the nurses and doctors that can take terrible abuse, not just from patients. We kind of expect that is part of the job, I suppose, really, but from family members and visitors. It's a growing concern anyway that I observe every time I go to work. So I just want to commend the hard work and dedication of all our hospital team, from doctors, the nursing family, domestic and support services, and everybody else. My questions is really about the increase of surgery we've seen lately. There's an increase of surgery going on in the SWA, which is good. But we don't actually want this to be used as a trade-off for the loss of the emergency surgery services, and you have spoken a lot about that. But I'm just wondering how many residents of Fermanagh and Omagh are actually benefiting from this. I don't know if you've got that information, and if it can be got and sent afterwards, I'd be happy enough. And are there care plans put in place for people? Because I think, and you can correct me if I'm wrong, that these are NH patients probably getting surgery from NHS surgeons, but that it's being done on a private contract. So that's one issue.
I'd like to ask if there are any services in SWA or OMA hospitals that are at risk at this time. Are there any other services at risk of us losing? We've heard before that the MRI, and it's in the documents here that you've sent us, and I thank you for them, that the MRI scanner isn't fully utilised. And I'm wondering what is being done to increase that use, and if the Department of Health isn't commissioning, have you worked with hospitals in the south to help bring that up? You've answered the question really on the vision timescales, and I think you said, Teresa, you're not committing to an actual time plan, but that's fair enough. And I think the other question was, as beds are escalated on the wards and as many as 5 on some of the wards during the week there, are additional staff being rostered to provide the much needed additional care? And I was also going to ask you if we could get a list, if the council could get a list of all cross-border services and schemes and collaboration work that's going on. And I've been asked to ask this, and I think Adam alluded to it anyway, have patient outcomes increased or decreased for patients that have been transferred from the SWA to other hospitals due to the suspension of emergency? And I think that was kind of answered, but if there is anything else to add on that. This is second to last. My biggest passion is community care. And I know that there's been an increase in home care, but has that just replaced the loss of Northwest Care? Because that was a big loss to the area. So is this increased care on top of what we actually lost at the end of last year? And I know that there was a good video from the trust, and it might have been Mark that was on it, asking people during the week to, consider trying to take their loved ones home, because I'm not sure if it was you or not, was it? No, it was somebody who looked like you then. But somebody done a video, and there are people in hospital beds that don't need acute care. We're an acute hospital. That's what we're fighting to keep. But there are some people there that could move on. And so I'm just wondering, that's tied up with the community care. And if we can't sort out the community care, we're probably not going to sort out the bed issue. So it's really, really important. And lastly, the council commissioned its own health document that some of you was at. I know Chris was at the Manor House last year, and I'm wondering if you've looked at it, read it, and what you think of it. Thank you, Chair.
Okay. Thank you.
Okay, thank you, Chair, and thank you, Councillor Coyle. In terms of your 8 questions, the first one it talked about care plans, but also the private contract, really. I suppose it's as someone who's spent their entire life in NHS and is passionate about free to point of delivery, I want to emphasise that we are bringing in the private contractors as a last resort to use a spare capacity in South West Acute Hospital. These are theatres that aren't commissioned. So it's not something that we've actively gone out and sought, but if a theatre is going to lie not used for years, then I'm not going to apologise for actually using it for private use, because it's actually availing of NHS patients. It's the NHS funding them for NHS patients. So I think it's the least worst option. It's probably the best way for me to describe it. Would I prefer for it to be commissioned for the NHS? I would be absolutely much prefer that. So there is the normal care. It's my understanding. There's a normal care plan for when we commission the independent sector. Just the operation is done privately as opposed to in the public domain. Second question: any further services at risk? I think what I do want to say, when we started this journey due to the emergency change, I was quite reticent to answer that question, if you remember, because we had a number of specialties that had low numbers of substantive doctors, particularly obstetrics and gynecology. Today, when I sit in front of you, we've never had as many substantive consultants in obstetrics and gynecology. We have currently 6, and I think on the 7th, we now are moving. We only funded for 6, and we are going out for our 7th, and we know whether there will be an applicant. So is it closed? It's actually closed. So in the near future, we are confident of being able to recruit a seventh. That is unprecedented for Southwest Acute Hospital. And that was, remember, that was especially where I was sort of being very careful in my words because I was concerned, really concerned about that specialty. And everyone was saying this, oh, your maternity service will be vulnerable as a result of this change. We are now in the best position we've been since the hospital opened. Are there risks to services? There are risks to services in every hospital in Northern Ireland, particularly smaller rural hospitals. But I assure you, Councillor Coyle, we're doing all we can to create a substantive workforce. And in terms of nursing, we've transformed the workforce in the Western Trust and indeed across Northern Ireland by eradicating off-contract nurse agency. So we now have actually adult nursing waiting list to join the Western Trust. So we have stabilised our nursing workforce across the trust. In relation to the MRI not fully utilised, any of my colleagues wish to speak to that? Geraldine?
I'll have to come back and confirm there's a gap after the 2 additional sessions have been put in, but I can absolutely confirm we have no gap in CT. We're at our full capacity in terms of sessions. But I will confirm back to you, Councillor Coyle, around the MRI, but I doubt there's a gap, but I will come back to you. Thanks.
That's more the question.
Sorry, Councillor Coyle, just to go back to the elective surgery that you asked about. We've also brought in some additional elective NHS work. So we're doing pediatric and adult ENT. We're doing breast surgery that wasn't previously there before, and we're doing special need dentistry. So we are trying to move as much of our elective work into Southwest Acute Hospital and OMA as we can.
Okay, in relation to question 4, are there additional staff for escalated beds? There is a formula for that, Councillor Coyle, and Assistant Director reporting to Donna, who took the CMT through that formula in great detail about a year ago, but maybe less, maybe about a year ago. And there is a formula for that, so every nurse manager knows when they move to an escalated bed what the situation is. Geraldine or Donna, do they want to comment on that further in terms of the nursing director who's online?
Yeah.
Donna, would you want to speak to that?
Yeah, thank you, Chair. Thank you, Neil. Yes, we have a formula, as Neil has said, and again, we do bring in additional staff. We put that request out through our bank and our agency and through our own staff to try to fill the spaces when we have the additional beds up for escalation spaces. Sometimes we don't always get them filled, but the request goes out from the Trust because we support and we want to keep our services safe and keep our patients and make sure that we have safe staffing levels on all our wards. Geraldine, you might want to add something else?
I suppose we have a number of different options open to us. We have bank, we have agency, we have in the past 2 years increased our ED staffing at Band 5 by 14 new nurses. We find it really, I suppose, difficult at times to retain that because of the pressure. So it is a constant churn. But we're working really hard to try and maintain that. The escalation beds are an issue for us in terms of staffing, but we have to ensure that patients are safe, and we continue to make sure that we offer whatever is required to make sure staff pick up those shifts and come in.
In relation to question 5, Councillor Coyle, you're asking about all cross-border services. I think I would want to start by saying the Western Trust, has a really proud and excellent record of cross-border engagement. The COT partnership was set up under the Ballyconnell Agreement, which is a formal international agreement, and it represents border counties particularly. There are current work streams underway to explore any further opportunities and barriers. I think is actually equally important. And there's a review about to be commissioned to scope cross-border acute services, initially focusing on border hospitals. There's work ongoing to examine the flow of ambulances because they don't really cross the border at this stage except in major incidents. And we're really looking to get behind that, and COT are supporting that work as well to see whether or not we can unlock these barriers to cross-border cooperation. But there's been a bit of focus on COT recently, and comments have been made to of a health committee. It's not right to say that COT have done nothing for Fermanagh, and that comment has been made. COD projects have been available to citizens in every county and the border areas. I have a report which I have shared with the chair of the Health Committee yesterday, showing the beneficiaries across the Western area, particularly referencing Fermanagh. So this was based on the. There's been also discussions around how COT got Altnagavin's the Cancer Centre and Cardiology Services. That is factually wrong, Chair. This was based on a significant access issues for Donegal with 8 to 9 hours commute to Galway and Dublin from Donegal. And the Northwest Centre, Cancer Centre and Cardiology were formally commissioned by Dublin and Belfast and not by COT or the EU. There's nothing like an 8 to 9 hour commute in this area for Cavan and Sligo for surgery and emergency surgery. But I just want to assure you, Fermanagh does benefit from cross-border support, particularly through the EU programme, and we have analysis from COT on that, and we can share that with Council if you wish, Chair.
Please do.
So that's question 5.
And you'll just be as quick as possible with the remaining questions that Debbie has posed. Now, there is significant interest from members, so I'm going to have to revise my approach. I'm definitely going to bring you back in, Adam, substantively, but I'll work my way through the list.
Patient outcomes, I do believe we've answered that, Councillor Coyle, if that's okay. In relation to community care, absolutely. I have to highlight to Council that since I've come into the Trust, I have been disappointed in the fact that the Western Trust has at least 500 less nursing home places than any other trust in Northern Ireland. That is as a result of the amount of resources that have been tied up in hospital services. We have to acknowledge we get our funding by capitation, but that is skewed towards hospital services. But in the last 18 months, we have increased our bed complement by over 90. So we're working our way towards it. We haven't got the money to do 500 overnight. We're just trying to do this in bits and pieces. It's unfortunate that hasn't been tackled earlier, and I accept that. In relation to domiciliary care, yes, you're right. We have increased the productivity within domiciliary care through our rota optimization. And that is really across the Western area. That has generated the equivalent of 230 staff's full-time hours in terms of extra productivity by everybody being a wee bit more flexible in terms of our service users, our providers, and indeed the trust. So everybody wants their domiciliary care at 8 o'clock in the morning, at 1 o'clock at lunch, and at 9:30, 10 o'clock at night. And if everybody moved, and everybody has, all the providers have worked really well with us, and we've been able to generate that extra activity. But you're right, Northwest Care, the dairy company, have pulled out of Fermanagh, and that service has been absorbed by the Fermanagh providers. It has been a tricky process to go through. The staff are chuppied over between one provider and the other, and we're still working our way through that. I have to acknowledge that. But there's a bigger problem. It is really difficult to sustain home care and domiciliary care in rural communities in Fermanagh. What I want, we have a formal legal tender we have to get through. When we get through the other end of that, I want to sit down with local communities and see, is there a better way? Well, maybe somebody else, Chair, to be honest with you. But when we get through that process, we need to sit down with the local communities and see, is there a better way of doing this? Because I firmly believe in Northern Ireland, neighbours will look after neighbours, but they won't join big agencies and they won't join the trust necessarily because they don't want to be a full-time care. So I think we have to tap into that in some way through local villages and local community groups. And that's difficult to do when you've got a formal tender, as you know. We have to go through the formal legalities of that, and we'll see where that takes us.
Okay, thank you for that.
And then in terms of the ICLRD, Teresa, do you want to have a quick comment on that?
Chair, I think with time, I can just assure members that I'm meeting the Council Chief Executive and John Boyle as Director, along with Shane on Monday. We have some comments on that, and I think it's important to understand where that will go next. So we have that lined up.
And just on that, Teresa, it's my understanding that there doesn't need to be a further iteration of that document, that it has been signed off by the council already, so that might be a point of disagreement.
That's fine. I think it's still important that the council have a rounded view of any issues that we would have with the detail of the report, Chair, and we'll provide that.
Thank you. Now, right, you'll appreciate, members, that there's a significant number of contributors. Now, I'm going to go to Councillor Eddie Roof next. Then I'm going to go online. Okay, so Councillor Eddie Roof.
Thanks, Chair, and thank you for the presentation. The main or the first point I'm going to go through is based on the mortality data that had been detailed by Dr. Labry, in which you stated that it was 3.1 between 20 and 22 and 2.6 onwards. Now, that does suggest improvement, definitely, and with the volume of patients, that's it's not an unsubstantial number of people surviving based on that. But we all know prior to the withdrawal of emergency general surgery that there had been retirements and resignations, and that service was operating on a locum service. It was not operating as it was prior to that, where there had been staff there for many years in a more stable service. Are we going to be able to look at data prior to 2020, when we did have a more stable team, to really properly compare the mortality rates when a fully functioning service is up and running? Because in reality, if we are going to compare a locum team against a fully serviced team in Altnagelvin, we're really comparing apples and oranges at that point. Then separately, following the Stormont Health Committee that you met in November, you'd stated that investment would be required for interventional radiology, the renal services and the bleeding rota. Now, we did have, I remember speaking to them, we did have someone in the radiology team prior to the general surgery being removed that did actually have the qualification to do that. So, and they left because they didn't want to, they wanted to keep their skills. So that they are in the ether, and they certainly, I think, were from the Bay Area. So there's an opportunity there long term, I would hope, to be able to get that. But the standards, that would allow us to meet the surgical standards from 2022. But you accept that the standards are not being met in the Northern, the Southern, or the Southeastern Trust, and they are still providing emergency general surgery. But I do welcome that clarity. I really do appreciate that you've put that stall out as to what we need for the restoration to occur. And part of the call from the Health Minister to produce a vision plan emphasising how this SWA would be supported to meet the needs of current and future population. Could you tonight commit to providing a costed plan as to what those interventions and improvements would cost? Firstly, to get us back to a restoration, and secondly, what they would cost on an annual basis going forward. Because I fully appreciate that you guys don't have the purse strings on this, and that you can only really do what you're commissioned to do on that front. I accept that. But we, as a population in Fermanagh, we have to have the ability to go to the Department of Health and say, this is what it looks like, this is what it needs, and what we believe it needs. And only you as a trust can really provide that accurate data for us. So how much it would cost to reinstate, maintain the service annually. At the time, it was 6 full-time equivalents. But I mean, we know that was not stable because of that. What does it look like for a larger team that would act as a proper sponge for the massive waiting lists that we have across Northern Ireland? And what would be saved as well in reinstating, because we know there are millions of pounds being wasted in ambulance provision privately and in the public service. The waiting lists are huge. We know that, and that leads to complications. And we've only seen it in patients in Fermanagh ourselves, where a patient who needed a simple gallbladder operation ended up with complications, sepsis, dialysis, ICU for 6 months, and died. Now, that's not a good outcome. We know that. And it's not the fault of the Western Trust that's happened. It's the fault of what the waiting lists are. But that patient in 9 months in ICU could have paid for 300 gallbladder operations. It's about efficiency. It's about trying to spend that money, because we spend more per head of population than anywhere else in the UK. That's public knowledge, but we're not getting the outcomes we need. So expanding that general surgery team across Northern Ireland it has to be the key priority. And when we have the operating theatres here, there's an opportunity there. Tonight in Altnagelvin, just checked, it's 8-hour waiting time in A&E, and we know that's pretty standard at this stage. Altnagelvin is completely saturated, and that is partly due to more patients coming from Fermanagh. It's an opportunity to reduce the pressure on the overworked staff across the board. So work with us, please, to provide that detail, the costings. Let us advocate for it to the Department of Health. And it would be up for them to decide at that point. And it could result in better outcomes for everybody in the Western Trust as a whole. So there's a couple of questions in there overall. So.
Okay,
I just want to add something before we go to Neil. Just from I'm an OMA councillor, I'm a representative for OMA, and there does be, for convenience, references all the time to Fermanagh needs, which is fantastic, and we back you to the hilt. But count us in as well. West Tyrone, Mid Tyrone, OMA, because that is our acute hospital at SWA. So just, I think it's very important that the wider catchment is referred to by members in these matters if you're so inclined. And that's not a direct at one person, it's a direct at a number, you know. Imagine I didn't say that. Okay.
Okay,
Neil?
Brendan will start off in terms of the mortality data, and then I'll talk about the interventional radiology.
Okay, so to start off with, the good news is we don't need to go any further back in January 2020. If I look at the RAMI scores, so this is the expected, basically deaths versus expected. The RAMI for Southwest Acute Hospital for non-elective surgery from January 2020 to November 2022 was 98.35. So it's actually just under what you would expect. So there's no evidence that the difficulties in staffing there had any adverse effects on the population. However, when we look at the combined RAMI from December 2022 to September 2024, that falls to 84.98. Now, we're not going to start talking about statistical significance, but that is a big fall. And that is all of the patients in the Western Trust who've been admitted to Alton-Galvin. Now, why has that happened? Well, it's happened because we have larger teams, we have better ongoing cover, we have no locum staff, we have fully complied with all of the emergency general surgery standards. We also have surgeons who are doing operations more frequently. This isn't a surprise. The EGS standards, they didn't come out of the ether. It was predicted that this would give better patient outcomes. What we are seeing here is what was predicted to happen. That is the whole purpose of the emergency general surgery standards. So good news, SWA outcomes at that time were fine, no issues there, but they're much better with the one service. Now, I'm just going to go back, and you've talked about how Alton-Galvin's been put under significant pressure due to surgical patients. That's a misconception. I've worked in ED for 25, 26 years of my career. The reality is the vast, vast majority of our patients on both sites who are waiting for beds are elderly medical patients. It's not like, you know, sitting and nothing is happening down there. At times, they've been up to, last week, we had the highest number of patients waiting for beds in Southwest Acute Hospital. The narrative that has been painted out there that Southwest Acute Hospital is quiet, is quite frankly, it's almost insulting to the staff. They are exceptionally busy as well. At one point, given the size of the department, I would argue they're probably as crowded as anywhere in Northern Ireland. You know, so this idea, you know, that if we bring surgery back into SWA, that'll solve it. No, absolutely not. Both hospitals are full with elderly medical patients. We would love to have more inpatient beds. That's what we need on both of our sites. We'd love to have more places to move patients out of. You know, we've got a big issue with dementia beds in the southern sector. That's a huge, huge problem. You know, it means we can't get patients out. But unfortunately, bringing emergency surgery back into SWA won't fix Alton-Galvin crowding, and it won't fix SWA crowding either.
Well, your second question related to interventional radiology, Councillor Ruth, we have to be open. So we lost that consultant to the Republic of Ireland. Republic of Ireland, their salary rates are more than double what they are in Northern Ireland. That's a fact of life. You know, it isn't that there's a steady stream. We only have one in the whole Western Trust area, one interventional radiologist, and we've had one for the last number of years just. So these are specialist roles, and they're really, really difficult to get. I just don't know how they'll be, one, recruited, and secondly, retained in Southwest Acute Hospital. It's not just the recruitment, it's actual retention over a period. And, you know, that's where we are. We are close to the border and we have to accept that that increases the vulnerability of this sort of thing. In relation to the commissioning, I'll pass over to Teresa and see if you want to answer that in part.
Yeah, thank you, Councillor Roof. So commissioning has a very set process within the arrangements that we have with SPPG. So as you know, the statutory role for commissioning is in SPPG, which now is in the Department of Health. And generally, they will make an assessment of need or demand or changing situations, and they will confirm a commissioning intent. And that's generally based around priorities that they, within the organisation that does the strategic planning for WHSC, will look right across Northern Ireland and see where they believe need is highest, investment would have most impact, and then they undertake prioritisation of that. And once they have done that, they would issue what they call a commissioning intent and a draft business case to us. And we would prepare the costings, service model, and we would set out a range of options. And this is required under the department's business case guidance. Formally, we have to comply with. So we would not prepare a business case based on a single option. We would prepare a business case based on a range of options that would meet need. So we have one option right now, which is the option that we're delivering, and that meets need. Generally, we are approached by SPPG when there's a very significant need that is not being met, and that is where they would customarily focus resources and investment. So the investments that have happened in Omagh and South West Acute Hospital for elective care, for example, they're a really good example of that. So in all of those areas, general surgery, urology and gynae, demand absolutely outstrips commissioned capacity, and therefore additional commissioning is being done. And we are completing those business cases on the back of an approach from SPPG for need that has to be met and they're willing to invest in. And that's how our system works, Councillor. If we don't prioritise within our own organisation. Prioritisation of this scale of investment would happen at a regional level and would absolutely fall to the organisation which has the statutory responsibility for commissioning, and that is SPPG.
Can I?
So we will respond if SPPG approach.
Can I come in as well, Councillor Ruth? I think we have to be open and honest as well. It's not just about money. We would have to be assured that the patient numbers will be sufficient to sustain a long-term service. And I'm just being open and honest about that to meet all the standards. So if you're bringing in all these extra staff, you would have to make sure that there was enough patients going through South West Acute Hospital emergency general surgery to sustain them into the longer term. You did mention one of my favourite topics in terms of the funding of the health service. You mentioned that we receive more than anywhere else in the UK, and that is factually correct. However, report after report after report has said that because of the health status of Northern Ireland, because of the extent of economic and other deprivation in Northern Ireland, and because of the diseconomies of scale, whereby in Northern Ireland you will need one of every service, whereas locations in England, Scotland and Wales will have a landmass where you're able to go to services where centralised within the UK. We receive currently 1.5% more than the UK than England. Report from the King's Fund, and it's quite dated now, was we need 10% just to match the outcomes of England. We need 10% more. And that only was from the health side. You can add more for the social care side, because in England, local authorities are responsible for social care, and they have other means of fundraising and revenue raising that the health service wouldn't have. So just to put that in context, the difference between the 1.5% and 10% alone would be, I think from memory, 700-800 million. The 10% is way out of date. We would believe that it's much closer to 15%. So you're talking about billions, at least £1 billion being short funded for Northern Ireland health and social care. So when people say you've got your money, why come the outcomes aren't the same? We do not have the funding that we would need to deliver the same outcomes. So we are at a crossroads in health and social care in Northern Ireland. Do we accept then that outcomes won't be the same as the rest of the UK? That's the sort of decision we're going to have to make when you move to 3-year budgets. Are we going to have to start making really, really difficult decisions? Or we fund it to the level that the people are saying that it needs. Northern Ireland wide, compared to UK, is funded at 24% more than England. So across all departments. Health is funded at 1.5%. I'm unashamed to say I'm an advocate for health and social care, Chair, and I will shout from the rooftops on that as long as I'm in health and social care. In terms, I think Brendan has already answered your question in terms of ED, your fourth question. Councillor Ruth, Geraldine, do you want to add anything?
I just want to add that we have not seen a major impact on the 2 patients per week being transferred. Councillor Ruth, we have the best ambulance offload times in the region. We have really strict processes in terms of patient flow, our site coordination hub around the clock. So we're not seeing the impact that you're describing to me today.
Okay. Now, what I want to do is, and I'm asking you all for your patience here, because everybody wants to come next. I'm going to go online. I'm going to go till Councillor Thomas O'Reilly and then Councillor Josephine Deehan. That's the next 2 speakers. So over to you, Thomas.
Okay, thanks, Chair, and welcome to the team there. It's good to see this open dialogue. From my time visiting the board and Neil and all of the rest of the team there, it's good to see this out in the public domain where the questions and answers are being given. Can I focus on slightly patient outcomes, but in 2 specific areas? One is the new health centre in Lisnaskea, and after 6 months of asking the minister through the council to give us a plan as to how that health centre would be staffed, the multidisciplinary teams, the GPs, all of the rest, to allow the patients in the Erne East to avail of the same level of healthcare as anywhere else. He has clearly says, oh, well, actually, that's all to do with the trust. Go and ask the trust. It's their job to tell you what that is. And that is in writing to the council, guys. So he has passed it right over to yourselves as a written document to the council to come back to us with a plan for how that will be staffed. So I'm interested to know what the costed plan is to be able to assure us about the staff in the new health centre, because we certainly don't want a brilliant new building without the clinicians and the surround staff to be in it. And my second area of concern is the whole area around endometriosis and the level of provision that we have for it, how we see the patients and the continuous juggling between gynae and surgery for sometimes many years before these women are actually able to get to somebody that is able to do more than a keyhole intervention on a temporary basis, where they're still going home and for many, many years suffering in agony. And even when, and I have a specific incident where I have asked to understand the pathway when even get to a point where a hysterectomy is required and is performed, that a patient post-operative, within a week of of surgery, in severe pain, would be pushed through the A&E department to have to go sit for hours in the A&E instead of getting back to the surgery team to sort of have whatever the concern raised dealt with there. No understanding, and I haven't got any response in over a month on that query. And it is about what we can do to follow up then on these patients, post the operation and all the rest of it? Where can they get to? Because there seems to be no direct pathway to get in for post-op consultation as to how they're doing. So I think it's becoming a greater recognized problem, and I understand that work is being done at a national level and all the rest. But I'm just very interested, Chair, as to how our local trust here is dealing with the many women who are suffering excruciating pain and are having to wait such long periods of time to get to see somebody for some help. Thank you, Chair.
Thank you. I'll pass over to Mark. He's going to answer, we'll maybe answer your second question first, and then we'll see about your first question, and we might have to come back to you on that.
All right. Thanks, Neil.
Thank you for your query, and I suppose it's something that we're absolutely focused on within the trust as well. And I am aware, Councillor, of your query, and I've read the query, and would be quite happy to engage on that outside of this meeting, because we have had some preliminary discussions about how we could avoid post-operative patients coming to the emergency department and navigating their way back to the gynae team through a pathway type approach. So happy to engage in that with you outside of this call. I think that would be very informative from my perspective. I suppose we are one of 2 trusts in Northern Ireland that currently provide endometriosis surgery, and that is complex endometriosis surgery. But currently we have a finite amount of theatre resource to support that. And indeed, there is a requirement for further capacity within Northern Ireland to manage that. Regionally, there is a newly established gynae collaborative, and that has taken stock of where investment goes in the future from a women's and gynae perspective. And absolutely, endometriosis and endometriosis surgery is on the page for discussion in terms of where further funding might go. Western Trust has developed an elective care framework bid for endometriosis surgery, and that is currently with the Gynae Collaborative for consideration. And to date, we do not have an outcome with respect to that at this point in time. But absolutely, we're committed to that type of surgery and want to be one of the centres in Northern Ireland alongside Belfast to continue operating on patients, not just for the Western Trust, but regionally as well. So we'll be happy to update council members as we move forward with those negotiations through the Gynae Collaborative, Neil, and happy to talk to the councillor off the call with respect to the query specifically. So thank you.
Thanks, Mark.
In relation to your first question, it is a little complex because we are in the middle of the implementation of multidisciplinary teams for GPs in the Southwest. So rather than me give you a very broad and not very detailed answer, maybe it was best if we just give you a written answer to that question to council, if that's okay. Chair.
That'd be great. That'd be grand. Thanks, Neil. Yep.
Very good. Again, coming to Josephine Deehan now, just in a second or two, followed by Anthony Feely, Rosemary Burton, Nolene Hayes, Victor Warrington, Dermot Brown, Colette McNulty, and I do want another substantive contribution from Adam as well. Okay, so next up would be Josephine Deehan. Councillor Deehan.
Okay, thank you, Chair. And thank you to Neil and his team for your engagement with us this evening. Now, I did hear rumours of Neil's impending retirement, so I want to take this opportunity to wish you well and to thank you for all your engagement with the council over the years. Now, I represent the OMA DEA, the OMA side of the council area, and obviously the Southwest Acute Hospital is our nearest acute hospital, and therefore we have a very strong vested interest in retaining it as an acute hospital, and particularly we want to see that our patients who have surgical problems are not disadvantaged in any way. Overall, I have to say, Chair, that the presentation from the Western Trust this evening, I found it overall to be very positive and very informative. And I think there are many good messages there, very positive messages which we welcome, particularly the stabilisation of the workforce and also the improved outcomes for our surgical patients in terms of reduced mortality, reduced levels of complications, etc. And also I want to acknowledge the challenges that have been highlighted to us this evening by Neil and his team. I suppose my first question really was, has partially been answered, and it was really how is A&E coping with the increased number of surgical patients presenting there? Now, in terms of because this pathway has been in operation for some years, GPs in our council area will know that you don't send surgical patients to the SWA, you send them to ED. So there will be more patients referred from GPs straight to Altnagelvin. Now, what I hear in my role as a GP is that in the emergency situation, and this is across all specialties, not just surgery, that in the emergency situation, the services that patients receive are really excellent, really excellent. I've heard very few complaints about emergency treatment, but what I do hear lots of complaints about is waiting times in A&E. And they're really, in my view, they have got to such a level that I have to really emphasize to my patients the importance of attending ED in an emergency. They simply do not want to go there because they know they're going to be faced with a very, very long wait. So I just wanted, notwithstanding Brendan's comments and Geraldine's comments, I just wanted to ask what measures are being put in place to address the increasing numbers of patients attending ED, because members of the Trust will be aware that GPs can no longer refer directly towards. All the patients have to come straight in through A&E, with the possible exception of paediatrics. So that was my first question in terms of A&E. Then I won't go over any area that has already been covered, Chair, but I wanted to talk about, well, first of all, I want to acknowledge the role of the Trust in taking over 3 GP practices within our council area. This was only ever intended to be a temporary measure, and I hope that it will be acknowledged that the cost of Trust delivering services from Trust-run practices is significantly greater than service delivery from the traditional GP model. So my question is, what plans are there to return to the status quo? I think it will require significant investment in primary care and in GP services specifically. What conversations, if any, has the Trust had with the Department of Health and the Minister regarding restoring normal service in those practices? And finally then, Chair, in the interest of time, I'll be brief. The presentation on health inequalities, truly horrific, and I'm particularly dismayed at the OMA DEA statistics. I spent 30 years working as a GP in OMA. I spent 25 years working as a counsellor in OMA, and yet these health inequalities are stark. I would like to ask the Trust, I personally believe that primary care services will play a key role in addressing these health inequalities. But my question is really, what are the Trust's plans to work with primary care services to address these health inequalities? Thank you, Chair.
Thank you, Councillor Deehan.
Okay, Councillor Deehan, in terms of the waiting times in ED, we'll maybe start off with Geraldine, and then I'll turn to Mark in terms of the surgical patients. Thank you.
Thank you, Councillor Deehan. And I suppose I would like to start by saying that we have, I suppose, done some work, first of all, in terms of bed capacity in our hospital in Altnagelvin. We know that our medical bed capacity is less. There's a gap of about 30 to 50 beds, and that's over a number of years. We have done that work, and we have not been supported to extend our bed capacity. Therefore, patients wait in our ED department. We have done a number of things, actually, in terms of alternative pathways. We have expanded our ambulatory care unit. At Altnagalvin, we have expanded our same-day emergency care unit at Southwest Acute Hospital as well. And this is not just the impact of the surgery, that the emergency general surgery cessation, the temporary cessation. This is about an increase in demand on our services. We have encouraged and asked patients who are thinking of coming in our media communications to look at alternatives. We've done that a number of times. Our OMA attendances have increased dramatically over the last 2 years, up now over 21,000. We have expanded our respiratory hubs, our cardiology hubs. We have put in place a short stay unit for patients that can be treated quickly overnight in terms of 24 hours. We have done so much, but I suppose the remaining issue for me is we don't have enough medical beds on site in terms of capacity. We don't have, and our chief executive referred to it earlier, Neil, around the community capacity. We have a number of patients delayed in our hospital, which adds to the reason why patients have to remain in ED and do remain in ED. So I suppose it's really difficult, and I apologise for any patient who is a long wait in ED. It is not the experience that we would want for any patient, but it is what it is, and it's a system issue at this minute in time. You will know from the system and the media across the system that waiting times in ED is absolutely very high at this point. Winter is difficult, but we have senior staff on site through a site coordination model managing the flow of patients on a daily basis. So our aim is to reduce that time for those patients and to get them to a bed as quickly as possible or discharged as quickly as possible.
I'll just, Mark wants to say something about surgical patients as well, just to say.
Yeah, so Councillor Dean, thank you. Just to say that the model of ambulatory care that exists in Southwest Acute was also initiated in Altnagalvin at the same time. Data from November shows that that service was utilised by over 350 patients. That was 350 patients in that month who did not require to go through an emergency department pathway. Again, there's direct access there for GPs, but again, happy to engage off the call as well, because if we have to refresh that direct access with GPs across the trust, then happy to do so, just in terms of what presentations can go there. But again, that same day access for advice to GPs or next day attendance and also reassessment as well. So happy if we think we need to refresh that to do that with the local GPs. Thank you.
In relation to your second question, Councillor Deehan, about the 3 GP practices that the trust is now running, the first comment I would make would be, we have stabilised those practices. We have expanded the service offering. We have appointed salaried GPs. So the challenges that we inherited around failing practices that were reliant almost exclusively on locums, largely eradicated. So when you say that the cost of the trust running the practice compared to GP practice, GP model, I've yet to see the evidence in that. We are paid on an invoice every month. I'd be very interested in challenging. I believe we are actually reduced the cost of these practices because we don't have the locums to anywhere near the extent that was before. So, and we are actually welcoming a discussion with the Department of Health, because if we've saved resources to the Department of Health, we'd be interested in seeing whether those resources could be expended in the Western area rather than just be going into the regional pot. So really, are we having regular conversations with Department of Health and Minister? Do I believe we'll be handing these practices back anytime soon? No, I don't. I think this is going to be in the medium term, because very few people are coming to me saying we want to take over these practices. I think there's a number of barriers to that, not least buildings, etc. But we have to accept that we are where we are. I believe we're delivering a very good service. I believe we've sustained the service. As I say, I think it's in the grand scheme of things, I think the Department of Health would see it as being a successful. We are supposed to be the provider of last resort. We are now a successful provider of GP services. I think it's something that we need. We need to use the practices that we're running. I think we need to get behind. Secondary care aren't experts in primary care. I think it's an opportunity for us. I've met with GP Leeds in London last week to try to move the modernisation of our leadership of the GP practices, to get better information, to use that information to inform, to try to co-join the secondary care information with the primary care information, and you almost use that as a pilot for Northern Ireland to see how can we work better between primary care and secondary care. So I don't see it as a challenge to primary care, Councillor Deehan. I see it as an opportunity for our practices to actually demystify primary care almost for the health and social care. So we are able to show, here are the challenges that primary care have. We're an honest broker almost in that, because we're primarily a secondary care service. So to me, I think it's into the longer term if we can use our information better. But I can assure you we are in regular dialogue with the Department of Health. I have written quite a few letters in relation to these practices, in terms of we were promised that we wouldn't be in charge of them into the longer term. But our attitude and the trust has changed. We believe the services are so important to the local population that has to be sustained, and we are quite happy to continue doing that. So our attitude and our sort of vocabulary around this has changed. We are now very, very content with the fact that this is an important service, and why wouldn't we? Why wouldn't we continue to deliver it? In relation to health inequalities, Teresa, would you want to pick that up for me?
Thank you, Councillor Deehan. Well, I attended your community planning partnership celebration event just before Christmas, and we have your fourth statement of progress on community planning, and it is the overarching vehicle through which the wider determinants of health are worked on collectively by partners, and Councillor Deehan chairs that forum. So I think we all have a responsibility, all statutory partners and wider partners, to work on those issues which are the wider determinants of health. I listened to Michael Marmot, who's famous in this space, and he said that in Denmark, and he spoke to the health minister in Denmark, who said to him, all ministers in Denmark are health ministers. We all work on a single agenda on the wider determinants of health. And it really, really struck a chord, I have to say, with the people that Professor Marmot was speaking to that day. So I suppose government-wide community planning is how we work together on that. Obviously, the focus on prevention is a responsibility of us all, but there is a statutory responsibility with the Public Health Agency. And we work closely through the AIPB, the Area Integrated Partnership Board, which was referred to earlier, and with the Public Health Agency and commissioned programmes of work on that. I couldn't tell you, Councillor Deehan, specifically those that are commissioned in the Omagh area, but I can certainly look at that if that's something you would like me to do. I think it's fantastic that under the auspices of community planning and AIPB, we have between us as partners selected those three areas that were on that heat map to work with and to engage with as communities to see what would have impact and improve health outcomes. And the Omagh area, Councillor Deehan, as John Boyle will confirm, is an area that the Council's own integrated wellbeing network is looking at. And I'm sure Council could provide to you the work that's been done so far and the outlook ahead on that. And then finally, I suppose, while it's still really being designed and in development, I know Councillor Deehan, GPs have been well briefed on the early thinking on the neighbourhood model, which is so reliant on our primary care colleagues as a real fulcrum for the success of that model. And I certainly look forward, and particularly because we are a primary care provider now, I look forward to how we can work as communities with primary care and other partners under the auspices of that model to improve provision of services, but also in the long term to work on prevention and improve health outcomes. Thank you.
Okay. Chair, if I could just make one very, very brief comment, please. I thank the Trust for their answers. It's, in my view, primary care, particularly GP services, need significant more investment. We have less than 6% of the total healthcare budget, and we are expected to deliver a high level, far-reaching services, including reaching into the neighbourhood model of care. So, I mean, I would contend that primary care needs an increased share of the funding. And finally then, Chair, in respect of the trust-run practices, I can tell Neil that for many years, those of us who hold GP contracts and run our practices in the traditional way have looked with great envy at the trust-run practices and all the additional services that those practices can avail of, like social work, for example, that we can only dream of. And we are continuing to dream of having those services embedded within our practices through the rollout of the multidisciplinary team over the next 6 or 7 years. Thank you, Chair.
Okay. You're another councillor, Councillor Dean, who's very good at finalies. Sorry. I was going to say, Councillor Dean, you're very good at the finalies. 2 finalies, but a good substantive contribution like the rest. Thank you. Now, I want to go to Councillor Anthony Feely and then Councillor Rosemary Barton.
Thanks, Chair. And I'll be brief, Chair, for I know there's a lot of people wants to talk. And I know it was a meeting about restoring emergency service at the Swan. There's an odd one was going off that, and we bit myself too included. But I suppose when we get a chance to talk to people from the trust, we want to ask our questions. Well, some of the questions that I had jotted down here has already been asked by Adam and Debbie, so I'm not going to go into them. And I just want to say, like, this meeting, there's a wee bit of positivity here tonight. Is that we seem to be in a better place than we were 2 or 3 years ago, and I welcome the comment from Neil when he says that, and I haven't said exact what service it is, but there's extra consultants and doctors in certain services in the SWA, which is good. So the rumours that were circulating about this is going to shut and the other things going to shut, it's not. So I welcome that, and I also welcome his talk about what there should be more cross-border cooperation. That is why I have down here as well, and I firmly believe we should have an all-Ireland health service, and that's why I'm going a wee bit off here tonight. And I've been at a lot of meetings lately, delivering rural health and care in a new island. And as somebody said at a meeting one night, all we need is a bit of common sense. And if we got a bit of common sense, I think that is the road we have to go down in the future. But I know shouldn't be talking about that tonight, but I just wanted to get that out there. And as there's a wee question in this, and it's a point I wanted to make is kind of that 6 months last year in relation to mine in hospital, and I was sick going to hospitals in Derry, in the Skilling and Omer Primary Care, and the 3 of them. And a real bugbear I had is if a patient was in, take for instance, and this actually did happen, in the Omer Primary Care for a month, and at the weekends and at some of the nights there's no doctor, they would have to be transferred to Derry, jaunted in an ambulance up the road with an elderly person, but would have to go to A&E there in Derry as well. Is there no way that, how would we go about this? Would any of you guys know that you'll get from bed to bed transfer instead of going to that A&E? He was there for a month, had all his medical records. I just wanted to, would anybody answer that question for me? Is there any way we could do that? For it's very traumatic on a person, and you're talking about the patients, their health and well-being, but that is a desperate situation to have to be done. And is that still continuing? And any way we could change that? Thank you.
Okay, thanks, Councillor Feely. Neil, who'll take that?
It's a good question. Can I look down? Geraldine, do you want to start, or do you want maybe, is it Bernie? Can I just check? Specialty?
The specialty was, if it was a palliative patient, that's a very different pathway, a very different process. And I would need to get Maura's team to answer that. I don't know if Bernie is there online still and could answer that. I suppose what I would say is that if there's detail that you have that you give me, we could look into it on your behalf.
Geraldine, just make sure the mic's close to you there, or you're speaking into it, please.
Sorry, apologies.
Okay.
However, where possible, we should go from a bed to a bed. And you've heard Mark talk about that and the improvement that has been made around surgical patients. So If it's a different specialty, we would need to look at that, and I could take the information from you outside of here, and we'll get back to you, Councillor.
Maybe I'll pass over to Brendan as well, just to say a couple of words, Councillor.
Yep.
Thank you. And I suppose the first thing is I'm always very wary about speaking about individual patients because we have to protect confidentiality. All I can assume is that
We'll lean forward here.
Oh, sorry. All I can assume is that the patient was acutely unwell and that they needed resuscitation and assessment in an emergency department. We can't send a patient who becomes unwell to a random hospital bed without knowing what's wrong with them. So they may need immediate IV fluids, might need blood cultures, they might need IV antibiotics, they may need some scans. And that's generally why we'd send a patient from an inpatient bed in a non-acute setting into an emergency department. But again, happy to speak to you in private if that would help.
Okay, thank you. And we just keep emphasising that mic bit because those that are online need to hear as well. And those that are tuned in. Okay, so we've completed that answer. Councillor Barton.
Thank you for your presentation here tonight. Just before I start asking questions, can I just beg to disagree with you, Debbie? Debbie suggested that she expected some abuse from patients when they came into A&E. I think you said something like that. People that come into A&E. I expect no abuse from anybody to your staff that comes in from A&E. I think you do a good job in A&E. You are hardworking and you deserve to be treated with respect by everybody. So that's just a start. Okay, yeah. First question actually is in relation to the ambulance service. Would you agree that perhaps that there has been greater stress put in ambulance service since the removal of emergency general surgery from the Southwest Acute Hospital? And the reason I ask this is I had a phone call today from someone from Councillor McElduff's part of the world who was waiting on an ambulance and were waiting over 6 hours. And so that happened in relation to Altnagelvin Hospital. And a few weeks ago, someone in the Fermanagh area also waited 6 or 7 hours on an ambulance. So that's the reason I ask that question. Now, my second question is, you refer, again, it's to do with emergency services. You said that you had 4 additional assessment bays in the emergency area, emergency department. Has that meant that you've increased your staff? Because the waiting times are still horrendous. I've had occasion to be in it on several occasions over the past couple of months. 7, 8, 9 hours I've been waiting. And I notice you've been putting out messages on social media. Please, as you refer to tonight, please do not come. We are inundated with people waiting. Is this inundation with people waiting or patients waiting to speak to someone in A&E, is that because you have more referrals now from GPs? And also, this out of hours care, I'm of the understanding that there are very often when there's no doctor in out of hours, that the people that should be attending out of hours are actually coming across to the ED department. So I'd like an answer to that. Third question, it's again around domiciliary packages. You said that there was an improvement, and I have no reason to say there hasn't been an improvement. I can't contradict you. But what I can say is I know people in North Fermanagh, they're waiting on the fourth part of four-part package. You understand the fourth part of it. And they've been waiting for 1.5 years, 2 years. And I know I have two constituents at the moment doing that, waiting on those, and they cannot get that fourth part, high up or low down. And in relation to that, you obviously have domiciliary care, which is provided by the Western Trust. Is there a limit in relation to the area that domiciliary care provided by the Western Trust attends? For example, is there a radius within a certain radius? Because I've been told, oh, we don't have domiciliary care from the Western Trust out here because we're too far out from Enniskillen and there's a problem with paying mileage, etc. So I've heard about that. My fourth question is, can you give me an update on any recent meetings you've had with DFI? And the reason, that sounds a funny question to ask you, and the reason I ask that question is the A32 road. That you have patients that are being transferred from Omagh to Enniskillen. It's not a pleasant road for some very ill patients to be transferred in the middle and travelling. It's quite distressing for some patients. And I'm asking, I know on council here, I mention it all the time. And indeed, the last time I mentioned it to DFI and council, we were told it could be 2030, 2032. Councillors here have heard that before there will be any improvements in that road. That is not acceptable. It's the main road to the main hospital from the Omagh area. And I think this needs much more immediate attention. And while we're trying to put pressure through council here on DFI, I ask and appeal to you in the Western Trust to try and put pressure on the DFI also, the importance of this road. Thank you.
Okay, Chair and Councillor Barton, thank you for your questions. I'll answer maybe the last one first. I know it's a wee bit back to front, but I have written on behalf of the council in the past to the Permanent Secretary of DFI to ask to highlight the risks associated with poor infrastructure in this area and the impact on health and health outcomes. It's my understanding, I think we had a conversation earlier, Chair, about the fact that, or with one of the councillors, that the health impact isn't being included in the assessment process for the roads. And I can assure you I've been supportive of this council in that regard, Councillor Barton, and anything more I can do. I'm quite happy to write letters, phone people, whatever you wish me to do on that front. I'll maybe ask, just go back to the first question now. I'll ask Mark to answer in relation to ambulance service, and then we'll go on to the others.
Thank you, Councillor Barton. We can work along with NIAS and ask NIAS to provide a response to council, specifically with respect to the response times and the query in and around response times. And we'll have to come back on that after discussions with NIAS. But I think I would also just want to say that NIAS have been key partners with the Western Trust since the temporary change came into place in advance of December 2022. And the reason why they've been with us on that journey is that we want to minimise the impact on them on a daily basis. Yes, we do use private provision, and the reason we do use private provision is to minimise the impact on Northern Ireland Ambulance Service, but only where it is clinically appropriate to do so. So every patient who requires transfer and requires ambulance transfer is clinically assessed by a senior doctor before they actually do that transfer piece. Just to say as well, I did reflect earlier on in terms of some of the learning that we've taken from the clinical audit work. And that clinical audit work with retaining patients in South West Acute Hospital without the need to transfer is also key to minimising the impact on Northern Ireland Ambulance Service. We also have an annual review process where we review the pathways in conjunction with Northern Ireland Ambulance Service. So the relationship is a very good one. And we talk to each other almost on a daily basis through Geraldine's team in terms of the control hub as well. Obviously, the HELO is in process as well too within Elton Galvin to support that process and that work, but very acutely aware of the finite capacity that they have and make sure that we need to use that in a judicious way, but we do that in conjunction with them. Thank you.
Before I ask Geraldine to answer the question in relation to ED, you said that we put social media out, please do not come. We've never said to people, do not come to ED. Just to clarify, I'm sorry, I have to do clarify. You'd understand. I would have to clarify that. It's please, if you have an urgent need, please do attend emergency departments. So I'm not picking Councillor Burton. I just really want to make that message because I don't want mixed messages to go out there. I know our EDs can be very, very busy, but my ED consultants are adamant. They want to see patients who need to come, and it's vital that we do that. But I'll ask maybe Geraldine to answer the question in relation to the base.
Just want to say as well, in terms of NIAS and releasing ambulances to those calls that come in, particularly Category 1 calls, as a trust, we absolutely do not have ambulances queued outside our hospitals because we made a decision a number of years ago to bring our patients in from the ambulance and cohort them inside our ambulance, inside our ED departments. So any category 1 call, which is a 999 call from the community, that ambulance crew are released immediately. And I just want to say that we also have expanded an ambulance offload bay to allow us to happen. And I suppose the added bit is our ambulance turnaround times. Again, I would state they are the best at this minute in time in the region. The extra bay is actually in our same-day emergency care area in Southwest Acute Hospital. So we have enhanced that service from it was 3 spaces now up to 8 spaces. We have added an additional doctor and the appropriate equivalent nursing staff and administrative staff. So we have increased the opportunity for patients, GPs, to attend direct access, to pull patients up from an emergency department that can be quickly turned around and get them away or bring them back the next day to follow treatment. So that's an ambulatory pathway that we've put in place, Councillor Barton. Thank you.
Maybe Dr. Lavery will say a couple of words on that as well.
Yeah, just to first of all commend our colleagues in the Northern Ireland Ambulance Service. They have finite workforce and there's no doubt that their workload is increasing. So we have access to an emergency care dashboard and we look at it pretty much every day. So that gives you an idea of the number of predicted ambulances that go to each site. When I left work today, every single site was red. You know, so they're transporting large amounts of patients. So there is definitely more work that they are doing and more demand for their services, unfortunately, which is very difficult for them and it makes it hard for them to reach their target. Getting back to the ED waiting times, part of the problem we have, although it presents itself in the emergency department, it's not the emergency department staff's fault. It's down to lack of space. If we had an empty emergency department with lots of cubicles, probably nobody would be waiting. But if you have 80 to 90% of your cubicles filled with patients who are waiting for an inpatient bed, it doesn't matter if you've got 2 consultants or 10 consultants, they can only work out of the same clinical area. And that unfortunately makes us very inefficient. And it's very frustrating for our staff to have to do this. And again, it really gets down to, as Geraldine has alluded to, we have put in a business case for additional beds in Galvin. We are down at that time, that was 2 to 3 years ago. It was recognised we needed an additional 30 beds. Unfortunately, they were not commissioned. We also need more beds in the community. We keep coming back to, we know what the answers are, unfortunately, but we can't commission those.
In relation to your questions on domiciliary care, I'll give Bernie a bit of notice here. I'm going to be asking her to maybe try to answer the second question. The first point that you made regarding people not getting their 4th element of their care is exactly the point I was talking about earlier. We really are struggling in rural communities to sustain the domiciliary care services. And that's true throughout the UK. But we need to do something different. And I think Northern Ireland is a prime sort of locality that we can try something different. You look at all the successes we've had in terms of community development in Northern Ireland, and I think we could really seize that. I think we're going to be forced into it in a way when we come, but we have to respect the formal legal tender process. But that's going to be over in a few months. And when we come out the other end of that, we will look at where we are compared in terms of the demand for domiciliary care and the capacity that these providers have. And then we will have to get into a dialogue with community groups, and probably people like the council will have networks that we don't have, to look and see what is the best way, getting around the table and saying what is the best way of providing this service. And it's really down to a person by person basis. You can't do that whenever you're commissioning hundreds of thousands of hours, probably millions of hours of domiciliary care in a formal tender, but you can when you're looking at the gaps. It's really about looking at the gaps and seeing how can local communities help us bridge that gap. That's the first answer. In terms of your second, in terms of the Western Trust, it's in-house teams. Bernie, would you be able to answer that?
Neil, I can. Thank you. Neil, there is no limit to where the Trust in-house service will go to. So we do provide a trust-wide service across all of our 9 geographical lots. What I will say, Neil, is that we try to rota our care calls into clusters within those geographies as best we can, so that we do not have 3 or 4 providers running after 2 or 3 calls, if you understand what I mean. But the basic answer is that no, there is no limits to where the in-house service will go to.
Just in case you're wondering, Councillor Barton, what that voice was, that was Bernie McCafferty,
Yeah.
who's the Assistant Director. Okay.
Okay. And that's the
That's it.
coverage. Okay. I want to go to Councillor Nolene Hayes and thank her for her patience, like everybody else. Thanks for your patience, Nolene, because you did make contact before the meeting with issues that you'd like to raise. Over to you, Nolene.
Yes, that's right. Thank you, Chair. And thank you to all the Western Health Trust team for coming to meet us today and for your presentation. I must say that I'm particularly positive news about the increase in consultants for obs and gynae. I have been campaigning for improvement in women's health since I was elected. And I think historically women's health has been inadequate across the Western world, basically, but specifically across these islands. So that is a welcome addition to that if we can help women get seen quicker and be listened to and be treated. On that point, I would, if you wouldn't mind, if I could actually join in the engagement with Thomas O'Reilly about the endometriosis, because I just too have constituents that have been suffering for years, and I find the system very, very frustrating. So if I could, if Thomas and yourself don't mind, that would be helpful.
That'll definitely be facilitated, Nolene. I've been advised that'll definitely be facilitated with the council. Okay.
Lovely, appreciate that, thank you. On the presentation, just a couple of things. First of all, little question, could you explain to me what a session is? You said you've increased some of these sessions on CT and MRI.
Session's half a day. Session's half a day.
Right, thank you. That was
Word.
just to clarify something. But I must say the main question I want to ask is, and I did put this through the council last September, and I'm yet to have a response from the minister either. But I appreciate if you don't have the details or points here, but I would like to ask, because it has been brought up to me by constituents. Out of the last sort of batch of newly qualified nurses that came through last year that did actually undertake their placements at South West Acute Hospital, have any of those been subsequently given permanent positions at South West Acute Hospital? And how many, if you could tell me that? And also, are they restricted to only applying for in the one trust area? I've been told this, I don't know if it's true. I would just like to have that clarified. So that's my question, and thank you, Chair.
Okay, thanks.
Okay, well, maybe in relation to, maybe I'll ask Donna, our nursing director, to answer those questions. Thanks.
Donna.
Thank you, Chairman. Thank you, Councillor Hayes, for your question. With regard to newly qualified nurses, wouldn't have off the top of my head the number that have been offered a post, but most certainly it's something I can find out and come back to you on that. With regards to the process of only applying to one area, the process regionally is that whenever you're newly qualified, you would put down your first preference hospital, and they try to work through that there to see if we can get you a post in that hospital. Now, if after a period of time that you haven't got a post or you haven't got the post that you want, because all our newly qualified nurses have been offered posts, some are still on the waiting list because they didn't get the place that they really wanted to work in. So they've decided to remain on the waiting list till that place comes up, or then they can opt to go on to one of the other trusts to their waiting list. But we've been very fortunate working and living so close with the Ulster University as well, that we do get a lot of our new recruits at the minute. So what I can tell you at the minute is that we have within the SWA at the minute, we have 12 waiting for posts at the minute, and we have 3 posts available. However, we have a nurse stabilisation process that we're going through at the minute, and we have more nursing posts that will be coming on board. So we will have more posts that will be coming out. And again, we will offer out those posts to the nurses, but it might not be in the area that they want to take the work in, so they can decide to wait on the waiting list or accept these posts. Now, we do encourage the nurses to take these posts and get experience in the trust, and then after a period of time, they can put in, for transfer to work to another ward. So that's what we try to do, is work with the nurses, encourage them to come on board in the first instance, and then see when they're in and get the experience, and then maybe move to another place. But I'll come back to you with the exact figures through Chris. Councillor Hayes, thank you.
That's great. Thank you very much. I appreciate that. Thank you.
Okay,
Thank
that's
you, Chair.
great. So remaining speakers, if I could have Victor, Colette and Dermot's approval, I will go, because I want Adam to keep up the momentum of his questions. And then I'm going to, if that's okay, there's a single dissenter. I won't. You have a lot of power here in this moment, Victor. We'll give way to Adam now and then come back to Victor, Colette and Dermot. Okay, Adam, over to you.
Thank you, Chair. And when I proposed this meeting, it was proposed as informal to allow a bit of kind of back and forth. So I'd appreciate if that was facilitated this time, and I'll try and keep it as short and sharp as I can, Chair. I want to go back to that point that was made earlier, that very first question that I had asked around the information not being correct. And we're here specifically about what was said at the at the Health Committee meeting. So I want to just read a few quotes here. In regards to when going to temporary consultation, Tom Frawley, Chair of the Trust, said, "We knew we would have to consult on permanent closure. We knew exactly the conclusion we would reach, and that was during the temporary consultation." When Neil was asked, or the Trust was asked, and Neil Guckian responded around this point, he was asked, was this a temporary closure? Because it sounds more like that it was at the time a immediate permanent withdrawal, or an immediate withdrawal of the service, not temporary. And to that, the Chief Executive of the Trust said, I agree with the latter point, that at the time it was, given that it was an immediate withdrawal that was agreed at the time. So in that vein of asking about this incorrect information, was that information presented by the Trust Board incorrect at the Health Committee meeting? And I will note that this conversation went on at length for a decent period of time, where it was said many times that the permanent removal was always what was going to happen, and it's there to be seen there. And I do want to say, it's important to say that there's been a point here made that there was in the presentation and at the Trust at the meeting of the Health Committee that the Trust Board have never given misleading information. So was the information given at the Health Committee meeting misleading, or is the information being given here tonight and during the consultation misleading? Because both cannot be true. One must be untrue, and both were said by the Trust Board. Both, obviously, during the actual temporary consultation, it was said no decision was made, yet the Trust Board have since said that a decision was made. They knew the decision that was going to be made. Thank you, Chair.
Can I just state, Councillor Gannon, what you've stated is not our recollection or the transcript of the meeting that was held with the Health Committee. So I think it's best if we circulate a transcript from the Health Committee, because at no stage did I say we've made a permanent change.
For the record, it is online. Watched it at a couple of days after, and watched it again last night. And the quote is very clear. We knew exactly the conclusion we would reach. That is a direct line by line quote, word by word quote by the chairman.
So we can get the transcript from that, because what I was asked was, if you were to return emergency general surgery to Southwest Acute Hospital, would it be a different service? And I said yes, it would be a different service. As a matter of fact,
I'm not quoting yourself. Sorry, with that quote. and
you're not-
quoting
he said
Tom Brawley.
he
The
said-
second question was, the second point where speaking about yourself was when I believe you're asked by Colin McGrath, MLA, at the time he said that you said this was temporary at the time, but it seems that it was a permanent not permanent, an immediate withdrawal of the service rather than temporary. And you said, I agree with the latter point rather than saying it was temporary. You said you agreed that it was an immediate withdrawal of the service rather than agreeing it was
Take an
temporary.
answer from that.
But I will,
Let's get an
I'll,
answer from that from me now.
that's
And
that's
that's,
trust.
and then following that, if necessary, I'll get some advice from Alison about how you handle interrogatory type engagement, you know.
Yeah. In relation, what actually, Teresa can answer this as well. What we were quizzed on was this an immediate? It's really down to the terminology and the regulations around consultation on temporary changes. And what the point we were trying to make is there is no categorization within the regulations for an emergency change. It's just the only ones we have is a temporary or a permanent. If they had a categorization for emergency or immediate change, we would have described it as an emergency or immediate change. We have to operate within the regulation of the Department of Health for change and withdrawal of services. It's either a temporary or a permanent. The consultation that we came under was a temporary change, and I'll pass over to Teresa to highlight that as well.
So the circular that we worked to, and I'm sure, and did speak about this at the Health Committee, Councillor Gannon, is the change or withdrawal of services circular. Now, at the time that services were withdrawn from South West Acute Hospital for emergency general surgery in December 22, there was an earlier version of the circular to the one that we have now. And that version still talked about temporary and permanent change, not emergency change. And of course, as we went out to do our consultation from January 23 onwards, we used the required terminology from the change or withdrawal of services circular. But we can certainly provide the slide deck, which was used at all of the public meetings that we had. And it was very clear that it was a matter of public safety. And that terminology is also used in the change or withdrawal of services circular. It's still called temporary. I mean, we as a trust do temporary changes. So things like, you know, we have a need to refurbish a building. So we pause services for a while if they're non-urgent services. Or we have a major workforce issue in a small service and we seek mutual aid from another trust. That's a change to a service. So this can happen. This can happen. But the significance of this really was not catered for within the circular. The fact that it was actually an emergency, but we did use the terminology within the circular, and that was temporary, because clearly we had not consulted on a permanent change, and it was a matter of public safety, and that is also catered for within the circular. So that's the terminology we used, and we worked within the terms of the circular. I did refer to this at the Health Committee, and it is that the circular has changed. And now the department circular, there is not a requirement to consult on temporary changes. That is a matter completely and entirely for the trust. The department don't take a view on that. However, we are still obviously required fully and formally to adhere to our consultation and involvement scheme and the circular for any permanent change. And where that change is very significant, very controversial, it clearly does need Department of Health and ministerial approval before it proceeds. I hope that's clear enough. Apparently. Thank you.
Okay. And I'm going to move now to Councillor Warrington.
Thank you, Chair, and thank you to the team tonight for their presentation. It's obviously been very interesting. Just a couple of quick comments at the start. I'm certainly glad to hear that our GP services, which the Trust is now operating, has been able to cut back on their use of locums, because obviously that was something that was obviously always going to be a concern because of the cost of locums. I think it was Brenton mentioned, somebody had said that the SWA ED was quiet. Well, as someone who spent quite a period of time with a family member in it recently, I can assure anybody who ever used the word quiet, they weren't in it or didn't see basically what was happening in there. And just on I was very glad to hear also the way that the SWA is operating the offload bays for people coming in an ambulance. Maybe that is something that other hospitals throughout throughout Northern Ireland maybe could look at, because certainly we regularly see, especially Antrim area hospital, we see regularly a serious queue of ambulances waiting to get offloaded, if that's the right terminology to use for it. One of my party's biggest concerns following the suspension of the service in the SWA was life or limb saving cover, when a surgeon could intervene to immediately stabilise a patient before onward travel if necessary. So welcome the increase now that we've had in the elective surgery, because that obviously in the probably the less likelihood that there is going to be a need for this type of intervention. The fact that we have these increased elective surgeries within the SWA, it certainly hopefully it would lead to a general surgeon being there on the ground and being able to, obviously, I'm sure if a general surgeon is asked to intervene or to help, but he's there for another reason, I don't think he's going to refuse. And also, just then in the last year, it was announced by the Minister that he had directed savings made by cutting down on agency and locum costs, and they were to use to employ over 20 new qualified ED consultants. That was across Northern Ireland. There's 18 of those now in post, is the information I've got. But our trust, who has appointed 3 of them, that is all Galvin, and none of them have been sent to the SWA. So maybe that is something I could get a response to. And I'll leave it at that, because I know it's getting late and there's other people who want to speak.
Okay, well, before I go to Geraldine in relation to the ED, I'll ask Brendan to talk about stabilisation of patients.
So I suppose we did this very early because this was an emergency change. It was all about mitigating factors, what we could do. So we've got our ambulance bypass. We have ICU with a blood bank, consultant-led ED. We can treat most of the initial problems in SWA ED, but then we also need help to get patients out. Okay, so there are many ways we can do that. We can use our colleagues in the Northern Ireland Ambulance Service, and we can also use our HEMS colleagues as well. So they will go to the roadside. They'll take patients directly to the Royal without going to the local hospital. And on rare occasions, they have landed in Southwest Acute Hospital. I'm aware of at least 2, and they've transferred patients from there to the Royal for emergency treatment as well. Now, one of the problems that we have with regards to elective surgeons is that the standards do say you can't cross cover. And this is one of the difficulties that we have. So we are constrained with what we have. We have managed very well so far, and we'll continue to try our best. Now, just before Geraldine comes in about the consultants, one of the issues that we look at is whenever we look at recruitment, we look at the number of consultants we have per patient. And what I would say that Southwest Acute Hospital, with the patient attendances and the consultant numbers, would have one of the highest number of consultant to patient ratio in Northern Ireland. So that would be part of the reason. And I'll let Geraldine take over.
And I suppose irrespective of that, Councillor Warrington, I am working with the team in Southwest Acute Hospital at this minute in time in ED, because they currently have 8 consultants. The numbers that Dr. Lavery is referring to, they probably should be at 10 based on the one consultant per 4,000 population. And they did have 41,000 attendances at the end of April 25, end of March 25. So we are working on an additional consultant to start with in terms of funding. And the basis of that funding is their current spend in terms of locum. And could they, you know, change that spend and divert that into substantive recruitment? So we are doing that right now. And just to confirm, that is what happened in Galvin. The level of locum spend actually allowed them to convert that into 3 consultant posts, 3 additional consultant posts, and still make savings based on their attendances. So that's a piece of work that's ongoing currently across the trust. Thank you.
Okay. So we'll move on then to Councillor McNulty, and thanks for your patience, Colette, as well.
No problem. Thank you, Chair. Thanks.
Patience with a C-E-N, P-R-T-A-E-N-C.
Very good.
Yeah.
Yeah, thanks to the panel as well and to the Trust. I have to say I must commend you all for the positivity and especially for taking on the GP surgeries in West Tyrone, Dromore, Trallick, Fintna, and for the rollout of the multidisciplinary teams who, through the health and wellbeing strategies in local communities that we do all play our part, and we're working together with elderly and promoting health and mental wellbeing and that. However, my question is about the Western Trust Healthcare and Physician Associate Programme, where the graduates have from McGee College. They want to know, is there a strategy to create PA posts in priority areas such as GP practices, emergency medicine, frailty services, or surgical teams? I suppose, is there a strategy in place? And if to maybe
I'll maybe
alleviate
start and then I'll look to my colleagues to follow on whenever I run out of things to say on that. There isn't a formal strategy, I have to confirm, Councillor McNulty. The challenge we have is that the number of doctors in the West is significantly lower than every other trust in the province. I give you I think I've told council in the past, we have 5.6 psychiatrists per 100,000 of population, despite the deprivation you heard about this morning. The rest of Northern Ireland, when you take our figures out, it's more than double that. So you're okay if you're up on the web in Belfast, you will get access to a psychiatrist, but in the West, you will really struggle to get access. And that's all down to the allocation of doctors. Where physician associates are great is where they can be part of a wider healthcare team and really provide great value added to that wider healthcare team. But what they aren't is they aren't a replacement for doctors who are on call and on a rota. Where we have to do is we have to really concentrate on building our doctors' rotas to make our jobs more attractive to everyone in the UK. And we have to put our resources into that. Every resort, unfortunately, where we are now is because the physician associates aren't a separately funded profession, we cannot say, we cannot create additional posts for physician associates. Well and good that they are, and they provide a fantastic service to a clinical team. But it's our priority, because we have such a dearth of doctors, our priority for our resources, it really is to try to build our rotas and try to build our clinical teams from the consultant down. And maybe I'll invite Brendan to say anything.
So as Neil has commented, there's no central funding. So part of the problem is we have effectively a system that has funded the education, but hasn't funded the posts. And that's really difficult for us. The other thing that we do have to be aware of, Councillor McNulty, is the Lang Review from England. So there have been a lot of changes made to how PAs work in the health service in England. And it is expected we will be following this at a certain point. So PAs have a fantastic role in basically helping with processing of patients, but we have to be very careful with the initial assessment of patients. So there are some very high profile cases where that has gone wrong, and PAs need appropriate education and support to do that, as Neil has said, as part of the team. So I hope that answers your question.
I'll finish off by being a wee bit positive, because that's the mid we're in.
I was just going to say,
we have employed, I just want to reassure you, we have employed physician associates in the West. It's just not at the levels of some of the other trusts in the UK. Geraldine, do you want to speak to that, or?
Just going to a few, and we actually have at least 2 in Southwest Acute Hospital in medicine. But the issue is they don't prescribe. So they can't prescribe medication. So, you know, where their range of duties then are quite restricted. We have a number of nurse prescribers, we have advanced nurse prescribers, we have advanced nurse practitioners, we have EMPs. So the need actually for a PA is reduced because they can't prescribe.
Well, can I ask just, so will that, better word than of course, will that stop now at the minute? Will there be a decline? Obviously there'd be a decline if there weren't posts.
I'm not sure. I don't know if there's been any.
You know, straight to
discussion
McGee
with
itself.
University or anything like that.
I think it's something we have to look. I think it's much wider than the Western Trust. Is probably the comment I would make. We met with Brendan and I met with the GMC. Actually, it was about a year ago, and we were highlighting this issue that you know we've developed this role. It is a really important role because look at the pressure health and social care is under. You know, but it does come down to a combination of resources and clarity of role and where they fit in, particularly in the out of hours system. You know, and because we're really struggling just to get the basic medical support, frankly, for us to employ greater numbers of physician associates, we would have to take the money out of the budget for another profession. And quite frankly, we know we have to have numbers of nurses per bed, so we know we can't do that. So we have to take it out, and we have vacancies in doctors. I'm really reluctant to put a pen through doctors' vacancies and say we will never go try to recruit them into the future. Because you have to be fair to someone you recruit as a physician associate. You have to give them a recurrent job. So you would then eventually effectively be reducing your medical complement, unless there's a strategy, as you say, overall for all the professions to say this workforce plan means we will employ so many physician associates across Northern Ireland, and this is what it will cost, and we will fund it accordingly. I think that's what's crying out for.
Thank you.
Thanks, Councillor McNulty. And again, thanks for your patience, Dermot. Councillor Brown.
Thanks very much, Chair, and thanks very much for your answers so far this evening. I suppose I just want to start off by sort of recognising the very, very difficult situation that you are in, trying to meet all the different pressures. And some very good work is going on. That's clear from tonight, from the presentation, which is very informative. And that we're seeing improvements in areas like reducing double ED waits and improved outcomes for patients and things like that. But I think we just have to recognise that there is a fundamental health inequality being experienced by people here in Fermanagh and Tyrone because of the removal of emergency general surgery. And people have an expectation here in Fermanagh that that will return in some form someday. The time and place will be decided in future, I suppose. But that you, as the leadership of the Western Trust, will be the biggest advocates for its return. And as you've laid out tonight here, we know that you don't have the resources, you don't have the staff. But I fully agree with what Councillor Roof proposed earlier, which was that you need to be bringing forward a costed plan to put it on the table for the Minister of Health to have a look at, because people will then take the view that you are fighting for it and that people will see you fighting for it. I want to bring it back to the cross-border health element of this, because that is vital. And I was glad to hear the update that there was work underway, small work that can continue and grow, I suppose. You know, it does beg the question that why some of this work hasn't been undertaken before now, because when the SWA was set up initially, it was envisaged that it was going to be a cross-border hospital, but we are where we are, but we have a lot to do yet, and we want to see that going further. And again, why have, there's a lack of leadership up to this point, but we hope to see that will change going forward, and that the Western Trust need to be that leadership role in advocating for the cross-border element, and people in Fermanagh are relying on you to be that provide that leadership. So please don't let us down. So, Chair, I'll just have a couple of questions now. And one, it was on the heat map about Enniskillen. I'm an Enniskillen councillor, and very, very concerning picture. on some of the outputs there. But there was a mention of Enniskillen having special attention, or some words to that effect was used. I'd like to know more about that. I'd like to have some of those details provided to see what can be done, and where's the community input into that, and where's, you know, consultation, and how do we all come together to create a plan, a community plan for Enniskillen in that sense. So if you have that in writing or at some other point. And then the other question then, you'll agree with me very much, Chair, that mental health is a severe issue in the Fermanagh and Ohm area, and people are crying out for the services which are struggling to get, particularly with the need for the OMA mental health unit.
Yeah.
So I would like to get an update on that, if you can, at some stage, maybe tonight or in writing. Thank you, Chair.
Okay, thank you.
Okay, Teresa, do you want to talk about as many of those questions as you can?
I'm happy to send you, Councillor Brown, some information on the Enniskillen area. Was discussed and agreed with council as Councillor McElduff knows, as an area for the AIPB to focus on. Now there is community engagement sessions being set up or has been set up. I just have to go and check my own records on that, and I would be happy to come back to you just even with a brief note just on what's intended, and give you a contact point that you could link with if that would be helpful. So happy to do that, Chair.
Yeah,
If that,
thanks very much.
Yeah.
And Rachel from your team, I think she works closely with Shane,
Armstrong,
would
yes.
be the convener of that
Yes,
event, you know, and I would be aware to a degree, and Joan Boyle would be aware as well if you want other conversations. It's about identifying in this council area a DEA where there is an intervention needed based on data, you know, and references have been made to Earn East Initiative and Oma Town initiatives in the integrated wellbeing network that John leads, and Enniskillen was identified. And the AIPB locally is co-chaired by Jenny Irvine and Neil. So that work is kind of ongoing. But, you know, if you were, as an Enniskillen councillor, wanting to insert yourself in the consultation with the community groups, I think you'd be welcome to do that. That'd be my advice. Aye.
Shane will organise that and make sure you get that information.
Just on the
Councillor Brown.
acute mental health unit, if I want to add my support to that, you know, and Geraldine, are you going to take that bit?
I don't want to take it. I just want to confirm that at the last subcommittee meeting, we agreed that our Director of Mental Health Services, Karen O'Brien, would come to the February meeting and have a one-item agenda from the Trust perspective in terms of the mental health services and an update on those services. So that will be February, Councillor Brown. Thank you.
And just today on that, I want to say that I met with a local community group, you know, Solus, on that very issue, you know, and I wanted to empower them. So I'll be in touch with Chris, you know, about a facilitated exercise where maybe some of the community sector will get in on that discussion, you know, about mental health services in their generality. And thank you, Chris. And Geraldine.
Can I just follow up then in relation to mental health? We'll have to come back to you on where we are with the business case. You know, it's my understanding we've submitted the business case. And it's all about the prioritization within the capital program. But we'll get you more detail on that if that's okay. Mental health is much wider than just a capital program, as you know. Whilst I am very disappointed in relation to the number of psychiatrists that we have in the West compared to the rest of Northern Ireland, we have to acknowledge two things. You know, well, mainly the thing is how we have really progressed in relation to supporting mental health patients in ED, whereby ED is seen as a place of safety. And we now have a new pathway in place whereby the patients either don't go end up in ED or they are in ED for a short period of time. And we have led the way in Northern Ireland in that through Rathview, which whereby we have a completely new pathway and we've transformed that service completely. Whereas 2 years ago, you come in on a Monday morning, there would be 5, 6, 7 patients in our EDs solely for mental health reasons. And that now doesn't happen. So it's been transformed, albeit I recognise totally that we do not have enough capacity in our mental health service, and so much so that our chairman has written to the minister and has had a head-to-head meeting with the Minister and our Director of Mental Health Services. It's such a crisis. So I don't want to use the word crisis. It's such a gap between demand and capacity in the Western area. And that the crisis service has really needs investment so that we can keep people in the community and support them in that service. But I can assure you it is a high priority for my trust board and for my trust generally. And we're open to ideas on how to improve.
Let
Sorry, I just wanted to include maybe all councillors just to receive the stats on that. And yes, the mental health unit in Noma just it needs big time refurbishment and maintained.
Neil mentioned Rathview there. The physical fabric of Rathview is what Elm and Lane needs to be.
Yeah.
You know,
Fair point.
the staff do a tremendous job, but in archaic buildings would be fair to say. So I think I'll leave it at that and thank our last speaker there, Councillor Brown, for his contribution and everybody else. Alison, you have a wee bit of advice just to offer the meeting now. Practical advice?
Practical advice, Chair. Members may be aware there's roadworks just immediately outside the Grange at the moment. So the result of that is there's no left-hand turn when you're leaving the Lisnelly Avenue tonight. So straight ahead or right-hand turns only and diversions are in place. So basically the Gorchin Road is closed until the early hours of the morning.
Okay.
Can I also advise people driving down, I suppose I was going to say about the Gorchin Road, there's a lot of surface water on the roads and there's been various warnings in the radio. So please, everyone please be careful as you travel.
Okay, now as I bring the meeting to a conclusion, I hope of everybody included here, but I want to thank Chris, Geraldine, Teresa, Shane, Brendan, Mark and Neil and Bernie and Donna and Karen from the Trust for this engagement this evening, good substantive engagement, and also on behalf of everyone in the council to convey our best wishes to Neil on his impending retirement.
Thank you.
Okay, thank you. The meeting is now ended. Nobody can speak after this.
Very good.
Speak now and somebody isn't.
Very good. Thank you.